Thanks, Kamel. Thanks, Baxter Egypt, for this interview and sharing our story about a patient with Oxiris filter. Last May, we had a patient who was 25 years old and had COVID pneumonia, which progressed into ARDS with secondary bacterial infection. He had, first of all, received all the Ministry of Health treatment protocol anti-inflammatory drugs, including antibiotics and antiviral medications. But he did not respond and progressed rapidly and was mechanically ventilated. We put him on veno-venous ECMO. After 1 day, there was clotting of the membrane and we had to change the ECMO circuit. The patient developed DIC. He started bleeding from everywhere. All his inflammatory markers started to rise. And we had planned that if interleukin 6 level became above 100, we may use the Oxiris filter to help controlling the inflammatory response, even if he did not develop renal failure. Then actually the interleukin 6 level was above 100. We started using the Oxiris filter. After 1.5 months, the patient recovered completely and discharged from the hospital. Thanks to ECMO, thanks to Oxiris filter, and thank you, Baxter, for helping us in this pandemic. And we are going to establish a new dedicated ECMO unit. And we are acquiring also the CRRT machine from Baxter again, because we can see the importance of cytokine removal and blood purification, in addition to the continuous renal replacement therapy in critically ill patients, especially ECMO patients who are hemodynamically compromised.
I'm glad to inform you that today this 25-year-old male patient is back to work as a contractor, living happily with his family. Thanks to Dr. Akram's efforts and his team's efforts, he recovered completely and pursuing a normal life.
Ladies and gentlemen, my name is Hani Salah. I am the Vice President of Baxter Healthcare and Head of ECMEA. And ECMEA represents East Central Europe, Turkey, Middle East and Africa, which is from Russia to South Africa, from Morocco to Pakistan, Afghanistan, which is 104 countries. Today, I would like to welcome you and thank you very much for taking the time from your patients and your families away to be with us in our ACE Symposium. This acute expert symposium that we are doing for several years, unfortunately, because of the current situation, we have to do it virtually. The benefit of this that we can invite more doctors and experts to join us in the same call, which is, up to my knowledge, we are almost having more than 500 experts on this symposium today, which is an amazing audience. But the other thing is we are not able to see you face to face, and really thank you for all the effort that have been done through the past years. We are all facing this unbelievable pandemic that nobody was ready or even dreaming about having in the past 2 years. Since the start, we are all thinking that it will take a month, 2 months, 3 months, and now it is taking more than 2 years, and it's not over yet. Unfortunately, with this pandemic, we lost almost 5 million lives globally, and more than 250 million people were affected with this evil COVID virus. With your help and support all over the place, on the ICUs every day, relentless effort from yourself, your teams, you were able to help sustain and save the patient's lives in a very complicated situation. So thank you very much on behalf of everybody for the tremendous effort. And this will be the focus of our ACE Symposium in this. We are bringing experts from all over the world. We have experts from USA, from Sweden, Austria, Russia, Romania, and more to share with you their experience of how did they do how did they do within this pandemic situation, some success stories, some complication, how did they handle it, and what is the global situation. From our perspective, as I mentioned, we are managing almost 104 countries, and within this different countries, we have countries with very high vaccination rate, countries with very low vaccination rate, countries with very good financial ability that are willing and able to bring the vaccine and do the support the patient much more than other countries, and so on. It is a complicated life, and it will not end, unfortunately, now. So we will be in this pandemic situation for the future time. God knows when we will be over. We hope, all of us, to be soon, and we hope that ourselves, our families, and our friends, and all our loved ones will be safe for this period of time. Thank you again for being with us. Thanks for all the panel that will be helping us through these days and giving us all their experience. Thanks for a very fruitful discussion that we are expecting out of this day. And we hope that you will all enjoy it and also benefit from it. And we are committed as Baxter to help you and to help our patient to do the best that we can do to save and sustain life. With this, I am inviting Kai Herensky, our head of medical for acute, to join us and to lead this symposium for the day. Kai, thank you for your effort, and the floor is yours.
Thank you very much, Hani, and a very warm welcome also from my side. My name is Kai Herensky. I'm the Global Medical Lead for Baxter's Acute Therapies, and it's my honor and my pleasure to be your host for this session. As Hani has pointed out already, this is not the first time that we organize these meetings, the first time virtually, but we had physical meetings before. For me personally, I always found them very informative and interesting, since this region, as Hani also pointed out, is a very large and a very diverse region, and therefore standard of care or the way you are treating your patients may be very different. And I always found it very interesting and informative to listen to your experiences. Again, the pandemic has changed, so we have to have this meeting virtually, but this is not the only thing that the pandemic has changed. Obviously, also the way you are treating your patients may have changed, and we thought it would make sense to gather global key opinion leaders, truly almost around the globe, I would say, certainly truly international speakers, to share with you their experience on various aspects of how they treat AKI patients, not only from an anticoagulation standpoint, blood purification, many other things that we believe will be beneficial to listen for you. Without further ado, I would like to introduce the first speaker, Professor Max Bell. He is a professor of critical care medicine from the Karolinska Institute and University in Stockholm, Sweden. Professor Bell will share with us managing AKI in a Swedish ICU during the COVID pandemic. Please, Max.
Thank you. It's a pleasure to be invited back to one of these symposiums. I'll try to keep this brief and to the point, and I hope that I can share with you some of our experiences. So, to be really brief, AKI, acute kidney injury, and ARDS has been interconnected before. It's well proven that ARDS is associated with an elevated risk of AKI. This was pre-pandemic. This was not COVID-19 ARDS. So the association was there and well known. And This has been shown in multiple studies from as late as 2019. And with regards to how acute kidney injury develops and how CRT should be thought of during the COVID pandemic, I have our own experiences, and I've also shared with experts in the field, especially peers from the ADKI peer review system. And I really like this consensus statement. I think it's highly informative and well reasoned. So when we're talking about why COVID-19, essentially a viral infection causing mostly respiratory dysfunction, but also highly associated with thromboembolic, why it also causes AKI. We can talk about direct viral effects and indirect effects, and so you have the direct viral effect with direct effects to the kidney, and this has been shown in a couple of studies that I'll just briefly mention. But we also have mainly the indirect effect. So we have patients with a lot of fluid in them. We have patients with low blood pressure. We have patients who are subject to medication that can have nephrotoxic effects, and all of this can lead to acute kidney injury, just like in a multiple organ failure setting, as associated with sepsis, for instance, or after a major trauma. So just to mention briefly, there are very interesting direct viral effects that can partly explain why AKI is so common in this viral ARDS disease as compared to other viral respiratory diseases. And you have the direct influence of the SARS-CoV-2 virus to tubular cells. So this is just to keep in the back of your minds why this is so prevalent in the critically ill COVID-19 patient. And this has been shown in some histopathological studies where you've actually seen SARS-CoV-2 in the tubular epithelial cells, and so this is a part of the pathophysiological pathway. And I don't have to go into this, but there is viral tropism and directly affected the kidney. And then there's the coagulopathical side way where the venous thrombosis, well known to be associated with SARS-CoV-2, can affect the kidneys as well as affecting multiple other organ systems. And of course, as you all know, the systemic inflammatory disease state within the scope of this viral disease is also affecting the kidneys, just like in all other settings of multiple organ failure. And then, as I mentioned, there are the indirect effects with inflammation, organ crosstalk, barotrauma, high abdominal pressure, and elevated intrathoracic pressure. So this all leads to the fact that in severe cases of COVID-19 leading to intensive care unit stay, critical illness, you will see a multiple reasons why the kidneys, as other organs, will be affected with COVID-19. And then there are risk factors, of course. These are the usual risk factors with, demographic side effects like other comorbid diseases, high age, etc. Nothing new, essentially. When you look at epidemiology, it differed. In some of the early reports, we had very low reports of need for renal replacement therapy. But then in larger European and US studies, the prevalence was higher. And again, this depends on how what patients you admit to your ICU, basically. So it's hard to really draw any conclusions. Personally, I don't think the cytokine storm is a big issue, but I will just briefly return to that discussion point when we talk about what filters to use, when we are getting down to the nitty-gritty of how we treat these patients. So basically, if you look at the consensus statement, the management of COVID-19 AKI does not differ very much from how we treat normal if you will, acute kidney injury within the critical care setting. So we base our strategies on KDIGO levels. When do we start treatment depending on how much the patient has an elevated creatinine, urea, and how much he or she has stopped producing urine. We also look at, as per usual, individualized fluid and hemodynamic management. And again, this is a dynamic measurement that I'm sure that you're all using. If you have a patient who's rapidly going up in creatinine and urea and rapidly losing urine output, that can be indicative of that it's prudent to start thinking about CRT. Whereas a patient who has been sort of stable, but you feel that he or she is sort of turning around in a critical illness, you can lie low and wait a while. And of course, we should also, always limit nephrotoxic drug exposure. It doesn't differ at all from regular management. And this is just sort of echoing what I just said. It's basically the same way, with a few exceptions. We have to treat these patients the same way that we treat every other critically ill patient with acute kidney injury. So, how you select your modality depends on, your experience and what you're familiar with. How do you choose your anticoagulation strategy? Again, sort of reflects your experience in your team. At Karolinska, we almost always use regional citrate anticoagulation, and that has been what we've been using throughout the COVID-19 pandemic as well. And basically, vascular access doesn't differ at all. But there are a few things I would like to share with you that I think can be important to know. So again, returning to this consensus statement, the authors from ADKI recommend, or at least talk about IHD and PD as the sort of rescue therapies or alternatives. I personally don't think that these therapies really have a place in the critically ill setting. But of course, if the accumulation of patients sort of overpowers your number of CRT machines, then we have to be creative, and I can return to that in a while, how we did it at Karolinska during the first wave of March 2020. Again, ADKI recommends regional anticoagulation, and I personally find that citrate really works best, and I felt that on a true day-to-day level, that some of these patients who I ordinarily treat with regional citrate anticoagulation in a regular mixed general medical surgical ICU, where we sort of target a citrate level of 3 millimoles per liter, I had to sometimes increase that a bit for the COVID-19 patient. They have a hypercoagulability state that sometimes demanded a higher citrate level, and sometimes we actually had to use regional citrate and add a higher dose of low molecular weight heparin on top of that. And in some cases, we actually switched to Oxiris filters, not only because they were septic, but also to improve filter lifespan, because they had some of the COVID-19 patients in the most critically ill part of the critical ill phase had a hypercoagulability state that was really hard to manage. And if we didn't increase citrate and or add extra low molecular weight heparin or add Oxiris, we were losing filters fast. They were clotting fast. So that's just a personal note. I found that to be really interesting. And then there's the discussion that I won't be able to solve, and ADKI just raises the point that should we treat these critically ill patients with Oxiris filters, with extra, using extra corporeal blood purification per se to remove cytokines, DAMPs, and PAMPs, etc. There's no evidence for this, of course, and it will never be tested in a randomized manner, but it has some biological rationale. It does. Some of these patients had very high inflammatory parameters, and this has been well reported in multiple studies. They have super high D dimers, they have super high CRP, etc. It really doesn't look like a normal viral infection. And would this be beneficial then to use Oxiris or other similar filters to remove these circulating mediators? Perhaps. It's not been tested, but it does make some sense. And again, this is something that's discussed, I think, extensively in the ADKI COVID-19 paper that I can really recommend, even though I wasn't a part of the writing group. We have a few sort of case reports on the use of Oxiris from Baxter in COVID-19 AKI, and I can share these slides with you. I won't go through all of them, but they are somewhat encouraging, I would say, in aggregate. Here's 10 patients from Brazil. They reported clinical improvement. And again, the COVID-19 consensus statement discusses this to some extent. I think it's something we ought to look into more in the future. I really think that Oxiris as a filter technique deserves more research attention in the future. And there are ongoing large studies, actually. So when we reported Claire Reimstiege, who was the last author of this paper, was my ex-PhD student. She's now, a fully fledged researcher on her own. She did this study with me and others. And we found that in looking into all Swedish ICUs who had a surge of patients during the first months of the pandemic, we really saw that almost all ICUs faced an extensive increase of patients, sort of overpowering the demands for machines and nurses, of course. And this is something that we should take to heart and plan for in the future. How do we store excess capacity if we have another surge, another pandemic? This is something that, at least in Sweden, we didn't have. We hadn't planned for this at all, I think, well enough. So I think this is something we need to take to heart and look into how we can improve in the future. How do we create excess capacity for when we need it? And Claire further reported on Karolinska and the outcomes of the patients receiving CRRT, looking at survival and renal recovery. And so in the first months, where she studied 451 patients, the incidence of AKI was 43%. So that was a staggeringly high number, again reflecting the demographic of our particular ICU system. So it's hard to translate these figures. It depends on your threshold for admitting patients and how many ICU beds you have, essentially. And a whopping 18.2% received CRT. So this is a more than a double of the normal number. So in our general ICU, we usually have around 10 to 11% of patients receiving CRT, and the same goes for a cardiothoracic ICU. But during the COVID pandemic, we were close to 20%. Most of these patients were male, 90%. They tended to be on the heavy side with a high BMI. 23% had diabetes. A lot of them had hypertension, and 6.1% had CKD, chronic kidney disease, prior to admission. They were all on mechanical ventilation, and almost 10% received ECMO, 8.5% to be precise. The medium length of stay was also something that stood out, and this goes for all critically ill ICU patients with COVID-19. They stay for a long time, right? So our median length of stay in our general medical surgical ICU is 3-point-something days, and these patients stay for 23 days. The ICU mortality of these patients were 39%, and the 90-day mortality was 45%. Risk factor for mortality was, of course, age, baseline creatinine, and body weight change. So patients who were gaining weight, i.e. Adding fluid to their system, had a higher risk of dying. Does this indicate that we should have started CRT even earlier without letting them gain so much fluid? Perhaps. This is really hard to study, and this was again affected by the surge of patient, and a need to be creative when it came to using the machines we had at our disposal. But to conclude, this large cohort study from Karolinska showed that these critically ill patients had a high 90-day mortality, much higher than our regular ICU patient, and at follow-up, 3 out of 3/4 of the survivors had recovered renal function. And again, this is also actually, to me, quite staggering numbers. The usual number of patients who end up with end-stage renal disease in our ICU CRT cohort is around 4%. So this was close to 25%, a major difference. And then Kamal and others from Baxter asked me to discuss change of medication. And actually, we did not basically change sedatives, vasoactive drugs, etc. What we do, the big question has to do with, and this is not specific for COVID-19, but do we change or do we adjust antibiotics? And what we do at Karolinska is we measure the levels of antibiotics during CRT. So when we have the septic AKI, the traditional septic AKI, usually caused by a bacteria, right? So we are then worrying that when we start CRT for those patients with septic AKI, do we in fact remove the very drug that treats sepsis? Do we actually, when we start CRT, lower the threshold of the antibiotics, going under the MIC value sometimes? And we have tested that for a number of years now. And a colleague of mine is writing up those research reports, but usually for meropenem and piptazo, if the patient has normal weight and we don't change the dosing of the antibiotics, we are well within the normal MIC limits. So we don't change antibiotics, we don't change them up or down. However, if the patient's overweight, we usually have to increase the dosage. So that's just a small nugget of information. I think this needs to be studied more, and of course it sheds some light on the dose studies from the early aughts. And again, like I said, we use citrate renal anticoagulation, but during the pandemic, in around one in 10 patients, we had to add heparin or to supplement the citrate regime to increase the citrate dosage, or use Oxiris for increasing filter lifespan. Looking at the ideal situation versus reality it's sort of interesting. This is a study. This is a slide I stole from Marlies Osterman, or borrowed. So in an ideal situation, when you look at CRT, you initiate the treatment before onset of life-threatening complications, and you prescribe your dose to compensate for unplanned downtime. And you have the optimal anticoagulation to maintain filter patency. You have a highly qualified staff, and you have a great ICU environment, and you provide a treatment according to high standards and benchmark. And you actually report and test continuously your own performance, right? Whereas in the true situation, and especially during a pandemic, you sometimes have limited resources and supplies. And this was very true for Karolinska during the pandemic, where we could have, I remember one night we admitted we usually have all in all 40 ICU beds, and we had increased those ICU beds to more than 4 times that number. So we had close to 100 beds, close to 120 beds. And we had one day we admitted more than 40 patients. And the number of CRT machines we had between us and the cardiothoracic ICU was around, I think we had like 18 machines or something. And we had more than 20 patients who needed CRT. So yes, we had limited resources and supplies. And instead of initiating the therapy before onset of life-threatening complications, we needed to apply stricter criteria. And instead of prescribing a correct dose, we had to limit the amount of fluid we used. And we actually, on a couple of occasions during the worst weeks, I had to use every other day treatment regime. So I had to use CRT for 24 hours for one patient, and then switch that machine to another patient, giving him or her 24 hours of treatment instead of having the 24/7 treatment we usually use. And instead of the optimal anticoagulation to maintain filter capacity, we saw a high risk of filter clogging and clotting. And instead of the highly qualified staff I usually have at my disposal at the Karolinska ICU, we had very varying staff experience. So we did have the regular staff as well, but everybody was overworked and overstressed, and we had to supplement those ICU nurses and some physicians with less experienced personnel. So that was a challenge as well. And again, yes, we had to move from our regular ICU environment to a non-critical care area. We could use a pretty good ward. We used the post-operative ward, which is very ICU-like, but it was different. So that was a challenge as well. And yes, we had to change the provision from the high standards and benchmark that we sort of pride ourselves with usually to lower standards with regards to dosing, machine availability, personnel experience, etc. That was indeed a challenge. And sort of the take-home messages from Karolinska during at least the first wave that was a tough one in the Stockholm area. We had to be really flexible. We had to really work together as a team and be creative with how we solve these impeding patient problems. We had to deal with shortage regarding machines and fluids and filters. We had great support from Baxter. We had actually great support from other hospitals who didn't have to take as much of a hit with regard to the number of COVID patients. So we could borrow machines from other hospitals as well. That was great. We had great help from the nephro staff. When the patients were stable enough to get off invasive ventilation, it could be moved from the ICU, and some of them still had need for renal replacement therapy. We would switch them to IHD in another ward. So we had helped them from the nephrology units. And like I reported, the prognosis for COVID-19 AKI is bad, and for COVID-19 AKI it is worse, but it's not dismal. I mean, at 90 days, after 3 months, more than 50% of these really, really sick patients are alive, and most of them have recovered the renal functions. And with regards to using sepsis filters like Oxiris, I think we ought to use that when you had a bacterial superinfection, and that was what we mostly did, with the exception of the fact that we sometimes had patients who were really, really hard to treat without getting the filters clotting. And in those patients, I think we had actually really good experience with using Oxiris because the heparin addition to the ST150 filter that makes up the Oxiris filter was really beneficial for us. With that, I thank you for your attention, and I'm happy to take questions if you have any.
Thank you very much, Max, for your insights, Swedish experience. Obviously, the virus has changed over the course of the pandemic, and there's one question: have incidents of clotting also changed during the course of the pandemic? It seems there have been more reportings in the beginning, and then maybe less afterwards. Is that due to people being able to better handle, or has the virus really changed?
Well, that's a really interesting question, because I have the same feeling without really basing it on true fact. But I do have the same feeling, and I wonder if the changed prophylactic regimen sort of has played a role, or if in fact the virus has changed, or both could be true, of course. But we did. Within, I think it's at least less like 10 days to 2 weeks, we did actually increase the prophylactic dose of low molecular weight heparin. So that might have helped a bit. But I did feel during the whole, like the first 2 months, the first 2 heavy months in Stockholm, that even though we increased low molecular weight heparins, we still had clotting problems with regard to CRT and general. You could feel it when you put in a central line in the patient. You were putting a central venous catheter for some other reasons, perhaps than then it wasn't a central dialysis catheter, and it would immediately clot. So they differ, these patients. And I do agree that during the second and third wave, that was not the same. That wasn't as prevalent. So maybe that was a viral effect or the impact of a change regimen.
And then also you mentioned the difference between the ideal situation and then the reality that you were had to cope with. Is there a risk that patients after the pandemic will continue to be treated as in reality, for example, with lower doses, or do you think there's a risk? Or
no, I actually don't. So during the pandemic, it was almost like when you're sick yourself. For a while there, I felt that this is the new normal. This is the way it's going to be now. And then I was sort of stuck in the feeling that, oh, we really need to lower our standards generally, not only regarding CRT and AKI, but then now when we are back, knock on wood, here in Stockholm, we are back to our very high standards that we pride ourselves with. We start CRT way earlier than allowing the patient to have life-threatening complications. And this is, as you know, an ongoing debate in the critical care community, but we feel that it's important to start early. And we do have I do it taking into account downtime, and I really do have an extensive planning, and I have a great staff that really works with me 24/7 for this. So no, I feel that we are back to the high standards that I feel that our patients really need. But it's also that simultaneously it was humbling and a great learning experience to create as safe environment as humanly possible with these constrained resources. And I do have to really say, this may sound like it's like I'm just being nice to Baxter, but you guys helped out a lot. I really got really good help from the Baxter team and from other hospitals who provided us with extra equipment when we needed it the most. So I'm extremely thankful for the cooperation we had, both with the industry and with other local hospitals. That was really imperative and essential for us.
There's maybe one final question, but I think you almost answered it regarding antibiotics. Shall there be renally adjustments during CRT?
So I think, again, I don't think that's not a COVID question, but it is an interesting question. And you and I have discussed this before, Kai, and others have heard me talk about this and harp on about it. But I think it's important that in some of these cases where we have a high dose of CRT for some reason, and that could be really prudent, that we need that high dose of CRT, so high clearance, we might run the risk of removing antibiotics. And we actually also run the risk of removing low molecular weight heparin. That's also a beneficial treatment for most patients. So again, if we had a time machine, I would go back and redo the renal and ATN study with adjustments of low molecular weight heparin dose and antibiotic dose. And that can't be done, but it's something we should think about when we treat our patients with a high CRT dose, or if the patient is really big. So it sometimes is important, but for most cases, your regular dose is fine. Just don't lower the dose. The patient has a lower GFR, but you're adding a machine GFR, so don't lower the dose. That's a mistake that traditionally has been made in some centers.
Thank you so much, Max. Thank you for taking this time in these very busy days. Thanks a lot.
Absolutely, my pleasure. Take care.
Take care, Max. We're moving on to the next topic, and this one actually will be a video that we would like to share. It's been pre-recorded as part of an educational program. It's from Romania, Professor Bedreac from Timișoara University. I should have mentioned before, obviously, although this is not an in-person meeting, there is the possibility to ask questions. Please use the link or the chat function that you're provided with, and we're happy to discuss them here. Maybe we will not be able to share all of the questions and answer them, but we will try. For this session, however, since it's pre-recorded, there's no possibility for that, but we will, in the next session, continue to do so. Please, the video, please.
Hello, my name is Ovidiu Bedreag. I am Associate Professor and Medical Doctor in Anesthesiology and Intensive Care, and I am also the Secretary of Romanian Society of Anesthesiology and Intensive Care. I am working in Timișoara, in Romania, eastern part of Europe, and this is our hospital. It's a regional hospital, 1,200 beds, and this was our intensive care unit before pandemic, a very nice intensive care unit, a large one, dedicated to both medical and surgical patients. But the pandemic was very hard for us. Like our colleagues from United States said, it was not a wave, it was a continuous tsunami in our intensive care unit. And right now, the worst is still to come, because everybody knows Delta variant is coming, the fourth wave is coming, and the unvaccinated people will be affected, and mainly because all the social distancing measures taken last year right now are not in place anymore. In Romania, until today, we had more than 1 million cases with a death toll of more than 35,000 patients. And the major problem is that until now in Romania, only a small percentage of population was vaccinated, because people are not willing to be vaccinated. The vaccine, it's available, it's largely available, but the people still don't want to get vaccinated. So we are facing right now the fourth wave, and we are on the red map of Europe, and the number of cases is increasing from one day to another. And at this moment, we don't have any place in our intensive care unit, so we are full of critically ill COVID patients. What we did during pandemic until now, it worked or not? So first of all, our National Society of Anesthesiology and Intensive Care tried to publish the best available guidelines for Romania, and these guidelines were based on European and American guidelines like this one published by East Virginia Medical School, developed by Professor Paul Murray. The main problem we faced, and you can see in this graph taken from Professor Paul Murray guideline, people were coming to the hospital not from the beginning when they were symptomatic, not in the early pulmonary phase, but usually they came to the hospital in the late pulmonary phase with low saturations in oxygen, and that means they came to the hospital around the 15th day since they contracted the disease, and it was very late to start the treatment at this phase. Very, very late presentation in our hospital. We tried everything we can for our patients. Regarding acute kidney injury, because this is the topic of our talk, we saw in our patients that acute kidney injury affected not only 25% of our ICU patients, but actually more than 35% of our ICU patients, because mainly we admitted patients in our ICU, patients that needed mechanical ventilation, patients with acute respiratory distress syndrome. And acute kidney injury occurred because of many mechanisms. we were aware that acute kidney injury should be treated. And very early studies published in the early 2020 showed that extracorporeal blood purification techniques may limit the systemic and inflammatory response. And that's why we tried to deliver continuous renal replacement therapy to most of our patients. So, indications for starting continuous renal replacement therapies in our unit were not only the classic ones before the pandemic, and classic ones being oliguria with refractory hypervolemia, hyperpotassemia, severe acidosis, or azotemia. And during this pandemic, for our COVID critical patients, the main indication was the cytokine storm. The cytokine storm, even in the absence of acute kidney injury. And for sure, we try to have as many as possible CRRT machines available for our patient. And this was a place where Baxter and his distributors in Romania were very close to our needings, and they ensured everything we needed for our patients. Vascular access, sure, we try to have as higher as possible vascular access, usually 13 French and preferably jugular vein. Second position used was femoral vein, and CRRT was started usually with continuous veno-venous hemodiafiltration procedure. The blood flow was as much as possible, usually more than 2 times the patient weight. And about anticoagulation, I would like to say that anticoagulation with heparin was preferred because these COVID-19 patients is clear that they are needing systemic anticoagulation, not only a local anticoagulation. So we used mainly heparin for anticoagulating CRRT in our patients. For sure, we tried to do our best for them. It's hard to say if the outcome was influenced in a better way, because we didn't have a control group, and because of the shortage of personnel, it was hard to introduce all the statistics. But we think, from looking back right now, that this kind of procedures helped a lot our patients. Yes, for sure, is not quite medical evidence, is not quite a good evidence to say, being subjective, to say, yes, it worked in our patient, but it was a standard of care in our hospital to provide CRRT for as many patients as possible when the patient was diagnosed with cytokine storm. And look, international guidelines said that even hospitals from well-developed countries, they had crisis in provision with continuous renal replacement therapies consumables. We were happy to work with good companies, and we can say at this moment, looking back, that we didn't have such problems. We were very, very happy because of this. What about removal of circulating immunomodulatory mediators? For sure, when we are discussing about CRRT, for sure, we are always thinking at adsorption, not only at dialysis or hemofiltration. And we tried as much as possible because we were aware that very good papers were published, like this one published by Dr. Villa in the autumn of 2020 in Critical Care, that if you are using a filter with enhanced adsorptive properties for cytokine removal in patients, this can lead to a better outcome for your patients. And even if we cannot say that we had a lower mortality rate, like in this study published by Dr. Villa, for sure we measured the IL-6 serum levels and we had a similar drop down in the level of IL-6, of ferritin, and for sure we had a drop down in the SOFA score. So we used mainly Oxiris. This filter, this special filter in CRRT, was used in our COVID-19 patients as much as possible. And when it was not available, we used standard filters. But first choice in our COVID patients was Oxiris. Regarding general considerations regarding renal support in our patients, for sure, one of the problems was prone positioning, because we were proning most of our patients, maybe all of our intubated patients, and that's why the right jugular vein cannulation was almost mandatory. And because of the hypercoagulability, that's why we choose heparin anticoagulation, and Oxiris was a very good filter also because he has a heparin-coated membrane, and his adsorptive properties led to a decrease in the circulating cytokines level. Another important issue we faced. We read a lot about plasma exchange therapies, and we started to do this in our patients. Therapeutic plasma exchange was a good thing for our patients, and even, like I already told you, it is hard to measure an improvement in outcome. Subjective speaking, we can say that providing therapeutic plasma exchange to our patients saved some of them. Until now, it is unclear if this is good for the outcome or not. Therapeutic plasma exchange, until now, it's not clearly stated in guidelines regarding COVID patients, but when we faced high levels of ferritin, high levels of IL-6, we started therapeutic plasma exchange in our patient, followed by CRRT with Oxiris filter or with a normal filter. But at least one therapeutic plasma exchange was performed in such patients. So my last message is that Baxter proved to be a real partner during this pandemic, and hopefully together we will go through this fourth wave, and this hopefully will have a happy end. And Baxter proved to be a real partner because they invested a lot in education of our doctors. They provided a lot of technical support, infrastructure support, bringing us enough CRRT machines, and for sure, they provided enough consumables for our patients. Thank you so much.
All right. I don't know exactly when this video was recorded. I think many are aware that the situation in Romania is quite dramatic. I hope that this has not deteriorated afterwards. With that, we will come to a topic that has already been mentioned, which is the anticoagulation and its changes. And it's my pleasure and my honor to introduce our next esteemed speaker, Professor Ioannidis from the University Hospital in Innsbruck, Austria, who will talk about anticoagulation challenges during CRT in COVID patients. Michael, please.
Thanks, Kai, for the nice introduction. I hope you hear me well, just to make sure. Let me introduce you myself. I'm an intensivist and a nephrologist, and I'm head of the medical intensive care unit of the Medical University in Innsbruck. Just to know that we have been a major center treating COVID patients, so the main center in the region, and I've been also the regional coordinator for the ICUs in the area. So we got quite a lot of COVID-19 patients which we had treated, including ECMO. But I don't want to share too much of my personal. I will share the personal experience, but I will give you some general considerations concerning anticoagulation we have to take into account. Now, in the meantime, it has become clear that the development of AKI in COVID-19 patients has many aspects, and probably the direct invasion of the virus in the kidney is only a minor aspect. We have the influence of underlying disease, drugs and rhabdomyolysis during the severe viral disease. And then we have the immune aspect, which leads to activation of cytokines, release of cytokines. And associated with this change, there's a major change in coagulation activity. And the observed fact that patients with COVID-19 tended to have increased rates of thrombosis and are more AV to develop increased anticoagulation parameters. Now, in the meantime, it pretty much turned out that the activation of the coagulation in COVID-19 patients follows the pathway which we know from severe infections in general. So it's an activation of the pro-inflammatory cells with loss of the glycocalyx and loss of anticoagulator factors which are within the glycocalyx. So netosis starts, and on the other hand, we have a development of extra large von Willebrand factors, and altogether clotting is triggered and massive thrombosis is formed. We can see this by biomarkers like syndecan release or von Willebrand factors measuring in plasma. Now, when we were analyzing our patients, this is a group from the first wave, where we wanted to see if it's just the procoagulatory factor or whether it's also the fibrinolysis which is impaired. We found, and this is the first panel, we found, and this was very interesting, that many of the patients, actually 75% or 70% of our patients had impaired thrombolysis. And those patients who had an impaired thrombolysis were characterized by having increased fibrinogen, platelet, and CRP levels, not so much D-dimer. So it might be you have a triggered pro-inflammatory pathway which increases coagulation, but you also have an impaired lysis of clots which is formed, and this together might be a problem. Now, we started quite early to do patients, to treat patients in the intermediate range of anticoagulation. In the meantime, there are big there are big randomized studies, just this recent one from the recovery group, where they found that in the moderate disease, systemic anticoagulation is of advantage. But if you have patients with severe disease, actually the organ support-free days seem to be reduced, and there is a tendency to increase bleeding if you do high systemic anticoagulation. Putting every COVID-19 patient into complete anticoagulation would actually be rather dangerous, and this is also the conclusion of those studies. But I think of note is this more recent study, which has been published in the BMG just now, where they included patients with therapeutic versus prophylactic dose heparin, and they had an additional parameter which they had to show for inclusion, which is elevated D-dimer level. So they had to have, so I have to put this off. So they had to have increased coagulation tendency. Now the question is, what was the outcome? So here you get a decrease in death from outcome when we have a patient who is procoagulatory, and you get giving those increased antibiotic thromboprophylactic or anticoagulants. Now this all transfers, of course, to renal replacement therapy, and I think coagulation is the major problem, and this is just in COVID and outside COVID, that when blood is coming into contact with the membrane, you have the intrinsic system which is activated. But in COVID, this might be a very important trigger, is the extrinsic system, primarily triggered also by the release of tissue factor. And this is an interesting aspect, because when the recent study was published, where they were looking at the tissue factor upregulation in COVID-19 patients, this is immunochemistry, and they were comparing RDS patients without COVID and RDS patients with COVID, staining for tissue factor, COVID-19 and SARS-CoV-2, platelet factor 4 and fibrin. And you can see that there is an increased rate of thrombosis in these patients of RDS and COVID-19, and colocalization of tissue factor and fibrin and platelet factor 4. And if quantitatively you see the tissue factor is increased. So this is obviously a situation which is specific for COVID-19 patients, and this might trigger enhanced coagulation activity when blood is coming into contact with external membrane. Then we have the complement activation. We have sludging, rolling erythrocytes which activate platelets. They release platelet factor 4. And then we, in a set of positive feedback activation, the release of procoagulatory factors lead to further activation of the coagulation system and clotting. Now we can intervene this either by giving heparins, which is then at the level of 10A, or we can give direct thrombin inhibitors, which inhibits thrombin degeneration directly, independent of the pathway. Or what we are doing now, just generally, and we did this also before COVID-19, what is giving citrate, which eliminates calcium, which you need for all these steps, and so you should have complete inhibition of the coagulation. As we heard before, there are two major modalities how you can do anticoagulation. You can do conventional anticoagulation, either systemic, which doesn't work so well, or you can do systemic anticoagulation at a lower grade, but adding it to the circuit, leading to higher values within the circuit. Or you can do it by regional citrate anticoagulation, and I won't go to other aspects because they are not relevant. Now, in the setting of COVID-19 patients, the dosing of heparin anticoagulation and filter clotting as compared to standard case has been investigated in this smaller study. And you can see that just increasing the dose of heparin systemically, even going to higher levels as measured here by anti-10A activities, does not really provide improved filter lifetime. So in those patients who still, even when doing higher systemic anticoagulation, when they're still clotting, you need alternative strategies to provide filter life. Usually other modalities. And I want to emphasize, this is an old story we did a couple of years before, where we administered low molecular weight heparins into the system, and not systemically. And as you can see, there's a clear difference when you put it into the extracorporeal system. You get just much higher anti-10A values as compared to systemic, and you get a better effect because you get, as compared to heparin, you get with low molecular weight heparins, you get prolonged filter time when you add low molecular weight heparin into the system and the circuit, which secondary can be enhanced so much that you get systemic anticoagulation. But nevertheless, the most optimal form, because we still have some clotting, is citrate anticoagulation. And we often forget about the correlation between how much you give citrate to the patients and how big is the effect on clotting. And as you can see here in this older study, but you see that when you go down with post-filter with the ionized calcium below 0.3, rather 0.25, then you start seeing a real increase in clotting time, so complete inhibition of the circuit. And on the other hand, you are impairing clot firmness. And as we talked, this is also relevant because thrombolysis seems to be, fibrinolysis seems to be impaired in COVID-19 patients. So going to higher anticoagulation with higher citrate levels and lower ionized calcium in the extracorporeal circuit might be beneficial for our COVID-19 patients. And actually, this was the thing we were aiming for. In the meantime, it clearly was demonstrated in several randomized controlled trials that citrate, independent of the disease, is always superior to heparin in anticoagulation in providing prolonged filter lifetimes. And these are just the major studies I'm showing you, and always you see the better filter survival with regional citrate anticoagulation. However, there were some observational trials where they could demonstrate, and here you see these three lines showing filter survival. And this is citrate anticoagulation in a patient who are COVID negative. And you see this is the usual behavior that you have quite long filter survival, usually up to 72 hours, but then you usually change the filter. But in the series of patients who had COVID-19 and had the same anticoagulation regimen, filter survival seemed to be shorter. This could be improved by adding heparin anticoagulation and citrate, so combining citrate anticoagulation with heparin. Now, in the multivariate analysis, it seems that COVID-19 seems not to be the real factor. At least it is just borderline significant. It seems that the usual parameters like hematocrit and platelet counts also play a role. But in the more sophisticated model of analysis, they found that it seems to be a correlation of D-dimer levels. So higher D-dimer levels showed increased clotting despite citrate anticoagulation. And this leads us back to the study of which I mentioned initially in the British Medical Journal. So these patients seem also to have an advantage when you give them higher systemic anticoagulation. This is just a discrimination between those patients who had higher and those who had lower D-dimer levels, and with lower D-dimer levels, circuit survival was longer. Now, one thing we have to consider is that when you still have clotting despite regional citrate anticoagulation, and another mechanism might take into place, which is heparin-induced heparin-induced thrombocytopenia, and clotting and repeated clotting might be an early sign of that. Now, this has been described a couple of years before, that these patients who had very short filter survival often had increased platelet factor IV antibody levels, and when you use alternative anticoagulation, the filter survival is improving. And you can see this even under citrate anticoagulation. And this was a case which was quite interesting, because this was a patient who had CVVHD, citrate anticoagulation, but needed thromboprophylaxis by low-dose, low molecular weight heparin. And certainly after a treatment of about 3 weeks, the system started to clot. Despite regional anticoagulation, despite CVVHD, and then HIT diagnostic was done, and it was positive. Then switching to an alternative systemic anticoagulation plus regional citrate anticoagulation improved filter survival, and no clotting was observed anymore. So this, especially since we have patients who are treated for a long period of weeks, and needing long treatment with heparins, the probability of heparin-induced thrombocytopenia might something we have to consider. Nevertheless, when doing platelet factor IV heparin antibody tests, we have to consider that, especially in the setting of COVID, obviously we quite frequently see these antibodies, but they do not correspond to the frequency of heparin-induced thrombocytopenia and thrombose formation. This is a quite interesting study which showed that a certain amount of patients is already positive with antibodies, but not only IgG, but sometimes it's IgA or IgM antibodies which are not specific. And however, there are few who are even specific IgG, and a number of patients develop these antibodies during hospitalization. Some show it even at the beginning, some develop it, and the majority is still negative. But the interesting thing is that even if you measure these antibodies corresponding to PF4 heparin complexes, they might not be specific for heparin-induced thrombocytopenia. And this is what we learned from the vaccine-associated thrombosis, where we have PF4 release and antibody formation, which is not due to heparin-induced thrombocytopenia, but these platelet factor IV release leads to the formation of very large von Willebrand polymers and impairs cleaving site for ADAMTS13. So we have there is an association with PF4 release and the antibody formation against this when they are highly stimulated, and we see this in COVID-19 disease, of course, and the procoagulatory situation and formation of large anticoagulative situation. Finally, independent of the coagulation aspect, we have to consider that these are the aspects we have to take into account when we do anticoagulation, and we still have clotting, is vascular access and the blood flow, etc. Just to mention shortly, when you do CRT, just prefer these two aspects. So the femoral artery and the jugular intervein, and avoid the subclavian vein. And we only used finally these large bore catheters with open holes no other approach within the last 2 years, because we had some issues with catheter patency, and you see, we saw some early clotting in our patients, and that's how it looked like. They obviously developed vein thrombosis or catheter thrombosis, and these were few patients who were really hypercoagulated or had massively impaired fibrinolysis. So if this occurs suddenly and early, think of that, the catheter might be blocked. Now, in any case, CVHD might be the modality which shows improved filter survival, independent of which anticoagulation form you are using. This has been shown a long time before already by Zaccaria Ricci, but this has been nicely confirmed, and I just want to mention that this in the recent study by Alexander Sarbok, where he compared citrate versus heparin. And when you look at the supplementary material and the influence of modality on filter survival, you see here the clear-cut differences that CVVHD is often significantly giving better filter survival than CVVH. CVVHDF is better than CVH, and of course CVHD is also still better than CVHDF. So just to keep that in mind, if CVVH doesn't work or CVHDF doesn't work, the alternative approach of CVHD is good. And the other thing is the relation of pre-dilution to post-dilution, especially if you have patients with high platelet count. The increasing pre-dilution leads to better circuit survival. And we generally had an approach of 50-50 pre and post dilution. So how to react to clotting in COVID-19 patients? You clearly have to discriminate between very early clotting or sudden clotting. This is usually a catheter problem, and you see frequent vein thrombosis in these COVID-19 patients. And we have to, in this case, to increase systemic anticoagulation and change the catheters. Late clotting is a problem of the system then usually, and there are 3 steps you can to approach. First, optimize the anticoagulation dose, then you can switch the modality, exclude heparin-induced thrombocytopenia, and finally, if everything does not work, you can try heparin plus citrate. But as I said, if you generally have the approach of putting the patients of intermediate systemic anticoagulation as a prophylaxis, then citrate alone usually should work, and this is our experience. We usually in this combination we didn't see very much clotting, to be honest, and most of our patients worked well. There's only one aspect. This is our protocol. As my colleague from Romania before told us, we also have a body weight associated blood flow rate for starting the patients, and we have the dose which is actually distributed about 50% pre-dilution and 50% post-dilution. This is how we usually combine them based on the blood flow, this dose. But, and this is quite interesting, with Fuxilium as a post-substitution rate, we had a quite high rate of metabolic acid alkalosis, so about 30% developed metabolic alkalosis in our cohort when we aimed at higher citrate doses. And a very easy approach to circumvent this problem is switching substitution solutions, and we switched from Fuxilium to Bifocil in this situation, which is a substitution solution containing significantly less bicarb, so that's 22 millimoles of bicarb as compared to 30 in the Fuxilium. And this worked then fine. So even if we aimed at a lower post-filter calcium, when we got metabolic alkalosis, we just switched the substitution fluid to a lower bicarbonate containing solution. So this was then our quite effective local approach. We used the intermediate high range systemic anticoagulation. If we had clotting, we did a very detailed coagulation system analysis and tried to see where we have to intervene. We used regional citrate anticoagulation. And interestingly, we had CVVH, and this worked fine in nearly all patients. And in the special situation of patients who needed ECMO and needed CVVH, and this was about 50% of our patients on ECMO, there we had, for other reasons I can't go into detail, we generally anticoagulate the ECMO patient with agatropan, and then since we always do this in a separate approach, have the CVVH on a separate line, we use here the regional citrate anticoagulation protocol I told you before, and this worked fine without any major clotting problems. So I was happy to show you a bit of our considerations, the general considerations of why COVID-19 patients are prone to increased rate of clotting and what we can do against it. And I will be glad to answer any upcoming questions. Thanks a lot for your attention.
Thank you very much, Michael, for this very informative and elegant presentation. We have a couple of questions. Some of them you have already answered about the combination of regional citrate anticoagulation and heparin, at least the systemic heparin. But there was one question also about infusing heparin through the circuit, pre-filter. Is that something you would recommend? And if so, what are the chances to aggravate bleeding in these patients, in your opinion?
To be honest, if you are doing or performing regional citrate anticoagulation, I'm very hesitant to add heparin in the filter additionally. As I explained, generally we have a different strategy. If you only do conventional anticoagulation, then it probably is better you put it in the actual corporal circuit. You can dose a bit higher, and you get still a systemic anticoagulation of the patient. You can target this, but then you have a very well anticoagulated extracorporeal system. So if it's your only anticoagulation, then I think extracorporeal approach would be better. And my recommendation would be using low molecular weight heparin monitored by anti-10A activity.
Thank you very much. There's been another question on catheter locking. What is your preferred anticoagulant for access catheter locking in COVID patients, and what concentration do you use?
Yeah, this is a very, very good question, because we saw these instances. And so we started in between the second and third wave, we started to lock with taurolidine, a citrate, to lock the catheters with that. So just the general concentration, I think it's 4%. And I to be honest, I can't say if this completely solved the problem, but we think, or we have the impression that this is better than the previous locking we had with that.
Thank you. One final question from my side. You mentioned that during recent regional citrate anticoagulation, it seemed that CVHD provides longer filter lifespan than CVVH. Wasn't that surprising? I mean, given the pre-dilution or not existing pre-dilution in CVVHD?
I agree, but I think this is probably a general physicochemical property of CVHD, that you have less hemoconcentration, and you might lose filter efficacy, which you don't see. But anyhow, I think whatever study you're looking at, CVHD seems just to run longer. And I think we can discuss it, but still, as we did all during the COVID pandemic, we still remained CVVH, and it worked. So what I told you, so I think we had we ever had no instance where we had to switch to CVHD.
On the other hand, though, I believe there's some evidence that higher pre-dilution as compared to higher post-dilution is associated with better filter lifespan. Is that correct?
This is clear. Yeah.
Okay. So thank you very much, Michael, for taking the time and spending time with us. We will move on to our next speaker. It again is a real pleasure and honor for me to introduce Professor Ravindra Mehta. He's a professor emeritus from the University of San Diego. And besides having authored numerous publications, he's also the host of the CRT Week in San Diego and elsewhere in APAC. And he also is hosting a website that is called CRT Online that I can only highly recommend. It holds very valuable information around CRT, AKI, and many other topics. Professor Mehta will talk about best practices for CRT, lessons learned from the COVID-19 pandemic. Ravi, please.
Thank you, Kai. It's a real privilege and honor to be part of this symposium. And following the eloquent speakers before me, I hope that I'll do justice to the topic. These are my disclosures, and they don't have any conflict with the current presentation at the point. So when we think about the renal support therapies in COVID-19, which has been a dramatic experience for all of us around the world, there are three aspects that I'd like to cover. The first, the epidemiology, the management, and the adaptations then as such. This slide should not come as much of a surprise to anyone in this audience, but just to reiterate, when we look at the possible options for managing dialysis options in any situation, particularly in COVID-19, we had to choose between intermittent, continuous, prolonged intermittent, and peritoneal dialysis. And as you can see highlighted here, there are obvious advantages in this, but the most important element here is the element of time. And I think that's one of the most important aspects for us to think about whenever we are thinking of CRT. Just as an example of what we know so far, this was a meta-analysis conducted in 2020, where they looked at 54 studies. The pooled prevalence of AKI was about 28% versus 46% in the ICU, and almost 19% in the ICU required a dialysis as such. But what was more important and interesting in this was when we look at the mortality of those patients who are in these in this cohort, the odds ratio of acute kidney injury and mortality was essentially, the pooled odds was almost 15-fold higher, and this was much more so when you require dialysis, as was exemplified by this other large study from multiple hospitals in the ICU in the United States, where you see the logistic regression and the 63% of the patients who required RRT died in the hospital. So a major aspect there. But what was really interesting was when did this mortality increase? And this was in terms of when was RRT being applied in COVID-19. And you can see to a large extent as the days process, in the first early part was when it was needed. And more importantly, there was a relationship to requiring of mechanical ventilation and the need for continuous dialysis at that point in time. So how did this change the management itself? And when we look at it from a broader perspective, the clinical indications for any form of dialysis could be thought of as those for organ support or for disease modification. And most of the time, we only consider in dialysis for renal support. But what I'd like to emphasize is that all of these other attributes here are equally important in that aspect. And when we think about continuous dialysis, the availability and the time that it is on board is a major factor to allow for organ failure recovery, and also the flexibility within these therapies coupled with the targeted interventions can allow us to use this for disease modification. But most importantly, we need to recognize the need for a multidisciplinary approach for this. So with that in mind, we can think about what were the challenges during the COVID-19 pandemic. And these can be classified in, obviously, the number of patients which came into the ICU at a much faster pace than before. There are challenges related to the thrombotic need and need for proning. And then the crisis of dialysis provision, related to all these factors, which I'll go into in a little bit more detail shortly. But let's think about what were the adaptations then. So when we look at dialysis requirements in any surge conditions here, and you look at this as an example of any pandemic or disaster, whether it be COVID-19 or let's say an earthquake, you have a substantially increased local demand for dialysis itself, which contributes to increased disposable consumption and the effects of the surge response. So this increased demand is also associated with reduced capacity because multiple other people are affected by this part. So this potential crisis can be at the level of the patient, at the level of the personnel, the RRT equipment, and the protocols. So when we combine this overall, it becomes a perfect storm, which we have to think about how to manage. And there are four aspects here which led to the adaptations. There were the technical considerations, the operational characteristics, the targets, and the scarce source modifications. And I will discuss this a little bit more. So the first aspect of the technical consideration was, where do you place the machine and where do you have this with respect to infection control? Recognizing that the PPE requirements with aerosol protections with COVID-19 made it difficult for personnel to be in place with the patients all the time, particularly when you have dialysis nurses and ICU nurses both managing the situation. So in many centers, this was changed by placing the machine outside the room, extending the length of the vascular access lines, and then performing the therapy in a similar manner. Now, this also led to obviously changes in the temperature. So you had to have higher heating for the blood lines to make sure that there wasn't hypothermia associated. But more importantly, this is although it has been practiced and done, there is obviously concern that these lines, even though they're taped to the floor, have a higher rate of disconnection. So we would not generally recommend this as a practice to be carried forward. The operational characteristics which are changed here to a large extent depended upon the type of patients. So Dr. Ioannidis has already talked very extensively on anticoagulation, but the access, the fluid management, and the dose were the other aspects. So the access in the prone position obviously becomes a little bit more difficult because you can't visualize the access itself. And as a consequence, keeping people in the prone position was more difficult. So there were some innovative aspects described in the literature. One of them was a popliteal vein catheter being placed. I'm not sure how many people utilize this, but it obviously offers an opportunity of an untested site from prior experience, which has now come into vogue, at least by some patients, some centers to be using it. Dr. Ioannidis did a very eloquent job on the anticoagulation, and I'd like to emphasize just two things. One is, regardless of what form of dialysis modality you use for continuous dialysis, it's really important to recognize the effect of filtration fraction, which is essentially the amount of ultrafiltrate as a proportion to the plasma. And if you keep these filtration fractions at levels of above 25%, there is more hemoconcentration and as a consequence, more likelihood of clotting. And as he emphasized, multiple studies, as was shown in this nice review published recently, has shown that even in the presence of citrate anticoagulation, there was obviously an advantage of adding systemic heparinization to this. To what extent this is required for every patient or those who are prothrombotic, again, needs to be deciphered a little bit better. But it seems from these studies that a combination of citrate plus systemic heparin might be needed in some of the patients who are more prone to clotting. And there have been multiple publications in respect to different protocols, and these exemplify how different centers approach this. So this, for example, is from Columbia and the New York Presbyterian. This is from Emory in Atlanta. And again, some of these protocols are available on the website, crtonline.com, that Kai mentioned to you, along with other several topics that may be of interest. In an ADKey meeting, we had then suggested that you could take an initial CRT anticoagulation plan, which is what your local protocol is, and then as a second line, increase the heparin intensity, and as a third line, add both a regional citrate plus a heparin intensification in a systemic manner, and other direct thrombin inhibitors, but also look into the underlying mechanisms itself. But most importantly, practice on a good vascular access. What is still a challenge and has not been well resolved is the fluid management. Because as we know, we still are not quite sure in terms of what is the pulmonary manifestations overall as such. And as Dr. Bedrag from Romania mentioned, when patients present, whether in the early pulmonary or late pulmonary phase, also needs to be addressed with respect to what type of fluid management can be done to maintain the fluid balance status without changing their ARDS needs. Now, the areas of therapeutic targets are something which has emerged quite dramatically during COVID-19. And as was shown earlier, when we look at the targeted extracorporeal blood purification options, these obviously depend upon the stage of the disease, the subsequent outcomes with respect to multiple organ failure, and the presumed mechanisms which are emerging in this. However, there is a significant discourse going on whether or not there is really a significant cytokine storm, or as some people have said, a cytokine drizzle. And I think that both sides are right. The difficulty is understanding what is the timing as such. But regardless of this, there is an opportunity to think about, are we looking at the cytokine damage, organ crosstalk, or the systemic effects? And all of these can and should be addressed overall. And as a consequence of this, there was emergency use authorization from the FDA for adsorptive therapies, including the ones for Oxiris, ones for Cytosorb, and also for the Seraph 100 hemoperfusion filters from Xthera. Now, common to all of these is a relatively understudied aspect of how often does adsorption help or affect all our patients, even whether or not they have COVID-19 or not. And I think that the knowledge we will gain from these experiences will go a long ways to what we do in the future. So the ADKey recommendations were, with respect to the timing, the vascular access site, were not much indifferent before, except for prone position obesity. We were recommending the same doses for the KDIGO-ACI guidelines, but as often as a hypercoagulable state, we were using of CVVHT or CVVHTF to decrease the filtration fraction and reduce risk of circuit clotting. And then the last part here was, I think, the most educational in some respects on the Scarce-Rose modifications. So what was important is, this was an analysis done in 2020 to say is what would happen with respect to the demand of and the amount of CKRT shortages. So they did a model of simulations from February to August 20, where looking at the demand for continuous therapies versus the capacity in the United States, and said, well, okay, if the demand is based upon those who required COVID-19 dialysis versus non-COVID-19 as AKI, 3D in the ICU, and the capacity is based upon the historical utilization and historic surplus. And what they determined by this model was essentially there was a shortage of almost 1,000 CRT machines at peak COVID-19 resource use. And this was in several states across the United States. And what was more important was that as you went from different base case scenarios to the best case scenario to the worst case scenario, you could see that the number of states where the CRT shortages would be there would be quite significant. And to some extent, this was exactly right. A second aspect was that because there was so much demand, there was bagged bicarbonate solutions could not be provided in the same way. So this is Dr. Marlies Osterman's group in Guy's and St. Thomas Hospital, where they created with their own pharmacy 2 formulas which just had saline and sodium bicarbonate added to it. And they utilized these 2 formulas in a very systematic way, depending upon which patients had a serum potassium level of more than 5. If they did, they used these solutions with 0 potassium to manage these patients initially till the potassium came down, and then they switched. So this way they were sparing the need for these commercial solutions which were in shortage. And they found that there wasn't much difference with respect to the electrolyte balances. In fact, they were quite maintained. So this is one approach to come across that part. A second approach some people started doing was to actually prepare machine-generated bicarbonate dialysis. Now, this had been previously shown by Dr. Paganidi's group way back in 2007. But this was now adapted for on-site dialysis production during the COVID-19 pandemic. This is from multiple centers itself. And what they found was that they were able to maintain the electrolyte balances itself by using this aspect. And they showed endotex and texin repeat chemistry for 3 samples itself. It's standard to negative. However, I would like to caution you on, and these are in some relevant years, discussions there. But what I'd like to caution you is from this other study, which was published back many years ago, where this is from Dr. Kangasundram from the UK, where they actually measured and tested different sites in the circuit and found that you had the microbiological results. You could actually have colony counts, which could be seen in multiple sites of the circuit. And what was more important is that the more manipulation you have of the circuit, the more likely there will be biofilms and also bacterial contamination. So just having a non-sterile bicarbonate dialysis traced through a dialysis machine may not necessarily preclude from an infection circuit itself. And this is relevant for almost all types of CRT, something that we need to look into a little bit more. The final aspect here was how the disaster response occurred. And this is really important to recognize. So this was in New York City. And what they found was during the usual course, they had 139 ICU beds. They went to 312. And at this point, they used to have less than 24 CRT cases. Now they went to 67. And you can see how this graph shows the marked increase in CRT requirements. But what they planned and did very successfully is to have a dashboard. And on the dashboard, they could map out how many machines were available, which service they were being applied to, who was getting it. And as a consequence, they could track this on a dashboard. But in addition, they could then pair the machines. So some of these patients got dialysis, they were shared. One patient got 2 dialysis, two patients shared 1 machine for 12 hours at a time, and they were switching them around by pairing this. Now, this obviously required a systematic electronic health record to be able to manage this part, but it just shows you that we do have the opportunity to optimize our resources in situations like this. So during surge condition, the most important aspect is obviously a judicious and safe use of all the things we do, particularly with elements to provide avoiding dialysis, as people have tried to do. If limited availability, have shorter durations. And then the RT dose was adjusted in multiple situations, as what Dr. Bell talked about, and Dr. Janidis and Dr. Vedra. These were all elements which happened there. But I think what's most important is the flexibility. We were able to adapt to that part. Now, a segment which I think is something we fortunately did not have to approach in our center, but was to recognize that if you have allocations of RRT and there are patients who are going to be futile and there's more demand than capacity, how do you manage it? And this obviously gets into the ethics aspect of things, but we had come across and developed a protocol like this of the contingency of nursing, contingency of machines and fluids being shortage versus there were ineligibility criteria. And fortunately, we did not get into the red zone as such, but this is something we would recommend that centers have in place. So finally, just to put this in perspective, there were several adaptations done during this part. We needed to obviously have a preparatory aspect. I think what it has taught us is that we can't go on just as normal all the time. We need to be prepared. We need to have this segment here. We need to have collaboration across local responses and view what we can offer at our center versus other centers. So a whole city, a whole state, all is working together. And then this can also be at a regional or national response. And I think this is where we need to focus on so that in the future, we don't have to be going through the same systematic aspects of individual centers trying to deal with this as such. So finally, I leave you with these thoughts. We need to have the flexibility in the approach that CRT provides, consider the targets and the practical considerations. I think that we've learned that no matter how well prepared and how advanced your hospital is, it can be overwhelmed. And therefore, we need to plan for it And then I think we will continue to learn more about how extracorporeal blood purifications will help us in managing these complex patients. And I'd like to end by just inviting you all for an in-person meeting in March in San Diego. We hope that this will provide further advances in knowledge and shared information across. Thank you so much.
Thank you so much, Avi, for this presentation and sharing your experiences that I find not only interesting, sometimes almost surprising. And it is unfortunate that we're not able to ask the audience now whether they had made similar experiences. But well, hopefully next year we will be able to do so. Ravi, we discussed obviously the ideal state as Marlies Ostermann has defined it, and then the reality during the surge and the pandemic that you also very nicely described, and how you have to adapt to this reality. Is there anything, let's say, positive that you can think of by adapting to the reality that may stay, or maybe something that we should, continue to do after the pandemic?
I think that's a very important and interesting question, and I was trying to allude to it. I think that the pandemic provided us an opportunity to learn the flexibility in the therapies, how we can adapt them, how we can monitor them, and I think the most important, that's added new knowledge. Just the fact that, as Michael showed you, now more knowledge about what the circuit does, what happens in terms of a immune response, the dysregulation, what happens to the coagulant factors, that's new information, which is now with a specific disease process. How that can be applied to, say, sepsis or other elements would be a learning experience for us. But I think the most important element I would say is a take home for us is the ability to share. We must share, we must collaborate, we must realize as single centers, single people, we don't have the capacity to handle everything all the time. We can learn from each other, and we need to have a system in place where we have crisis management protocols so that if one center is overwhelmed, they can borrow, they can adapt. And the other aspect is we need to share the knowledge and information so that people can learn from everybody around the world. And I think we have the ability to do that now because there's no limitation in exchanging knowledge. The fact that you're having this symposium, the fact that we have the ability of websites that are like ours, the fact that we have conferences allows everybody to go home and take a little bit back and change it. And I think from my perspective, the industry has learned a lot, because the fact is, if we've had the shortages of solutions, it gave you an idea where the solutions need to be prepared. How do you manage them? How do you facilitate it? So all of these are positive experiences, which I think for the future will not only benefit all of us short term, but long term, because it gets into a better situation as such.
Thank you very much. I think another learning that you mentioned from an industry perspective is also the ability to remotely or manage therapies and maybe also the tools that digital technologies provide us with may be helpful in that context. Thank you very, very much, Ravi. It's always been a pleasure having you. We have a coffee break now until, let's say it would be 5 o'clock Central European time, so 7 minutes, and we'll come back in 7 minutes. Thank you all. Goodbye now.
Thank you.
So we recently had a meeting with European experts that already had clinical experience using the Osiris filter. And the aim of the meeting was to learn from these people that are already using it what are their criteria for starting this filter, how do they define success, when would they stop it, in what kind of patients would they use it, etc. So we want some clinical experiments and see how people that have experience with the filter are using it, because this might aid other people that want to use this as well but have less experience at this moment. These experts that are using Oxiris in their clinical practice, the main patient groups so that had priority in using this were those patients that needed renal replacement therapy and had a high level of inflammation. So sepsis and septic shock is the main diagnosis that came up. And we also agreed that in other indications like metabolic disturbances, acid-base disturbances, rhabdomyolysis, there's no clear indication that this filter would be better than the other filters. So it's mainly related to removal of endotoxin, inflammatory mediators, and so septic shock is the main indication. If you have a patient in septic shock, then you still have to define maybe which one of these patients do you want to use the Oxiris filter. And the main trigger to use this was a high level of norepinephrine infusion. So the hemodynamic unstable patients, these seems to be the best patients to start this. And also the aim, and so also the measure of success of the treatment would be if you could lower the norepinephrine infusion rate, so if you would improve hemodynamic stability. So far, several clinical studies have been performed with also different blood purification membranes. And in many of these studies, mortality was the primary endpoint. And the experts actually agreed that this is not the optimal endpoint because it's so difficult to show an effect on late mortality when you do a treatment very early on in septic shock. So they agreed that actually improvement of hemodynamic stability would be the best measure of success of the filter. So if you would have a patient with a very high norepinephrine infusion rate, so he's really hemodynamically unstable, and you will put him on a filter, then there are a few options. He will improve, so norepinephrine infusion rates will go down, and then if it's 0 or if it's more like 70% decrease in norepinephrine, it's a success. And maybe you think you can stop and you can use a regular filter because the treatment was successful. If you have a patient in which you cannot decrease norepinephrine infusion rates after maybe 2 or 3 days, then you have to admit that it was not a success and you should stop for futility. It did not work as you hoped. And there is, of course, an in-between group that you have to decide. So there's a little bit of a decrease in norepinephrine infusion rate, but not that much, and then you have to decide per patient. But importantly, also in contrast how it was done in clinical trials, in which a given amount and a given duration of treatment with a filter was used, all the experts said we have to personalize that. Some patients might need it for a longer period of time, some for a shorter period of time. It's depending on hemodynamic stability and the response to the filter.
So welcome back, everybody. I think we're a little early, but why don't we take advantage of that? As you can have already maybe noticed during the video that was shown in the coffee break, we're shifting gears a little bit. Our next topic is, and we already touched upon it in some of the discussions, is going to be extracorporeal blood purification. And again, it's my pleasure and my honor to introduce our next speaker, who is Professor Marcus Broman from the University Hospital in Lund, Sweden, and he will share his experience in septic and COVID-19 patients with extracorporeal blood purification. Marcus, please.
Thank you, and good evening from Lund, Sweden. It's a pleasure for me to present my topic here on this symposium. I will try to present some hard data on endotoxin and cytokine balances, both in vitro and in vivo. And it is not very difficult because these balances are often extremely complicated and dependent on many input factors. But I start to go to the Mallard study, where the Oxiris filter was tested in vitro settings. And
it's 5 o'clock.
Of 15 microgram endotoxin spiked into the circuit, pumped through the filter over 6 hours, 6.9 microgram was absorbed. So it is highly effective due to its adsorptive mechanism. The adsorption takes place on the filter membrane surface, and the more endotoxin molecules attach to this surface, the more occupied with endotoxin molecules the membrane will be, of course, and the adsorption speed will go down. So during the first turn, about 2/3 of the endotoxin content in the fluid was adsorbed, and consequently, during following turns, this fraction went down. This is in vitro. Let's go to in vivo, where the endotoxin concentration operates on way much lower levels. From our own patient case publication, we have patient A and patient B. Both are in severe critical septic shock. They were both treated with Oxiris filter, and we examined them for 24 hours. As we can see, their CRP values are very high, and their procalcitonin values are also very high. We use procalcitonin in Lund a lot in order to determine bacterial sepsis. If we see on the endotoxin levels at the baseline, patient A had 0.14 units per milliliter, which is the same as 14 picograms per milliliter. And patient B had half of this concentration, 0.07 units per milliliter and 7 picograms per milliliter. That would equal as 70,000 picograms of endotoxin for patient A in the whole blood compartment and 35,000 for patient B if we assume that they had 5 liters of blood, and if we assume that the endotoxin is uniformly distributed within the blood volume. So for both these patients, between the 8th and the 16th hour, the concentrations came down to 0. As we can see in this series, there are a lot of numbers here, but if you look at them carefully from your screens, you can see this. For patient A, that meant about 30 turns of the complete blood volume through the filter, and for patient B, it meant about 10 blood volume turns through the filter. So the endotoxin is there in real patient. The endotoxin molecule is a detrimental molecule. It's no good. It is to be removed, of course. And the endotoxin is actually a motor for the septic cascade and triggers a cascade that results in a multi-organ failure situation. So we think that the Oxiris filter is fully saturated in 24 hours and needs to be changed if we are after its adsorptive function for endotoxin. No final data is available for this, but we have done some complicated maths on these balances and ended up in 24 hours. The adsorption process is dependent on the concentration in blood, of course, and on the saturation level of the membrane, and will follow an ideal so-called Langmuir isotherm formula that can be described mathematically. The endotoxin adsorption on the Oxiris filter depends on the area of the filter and the blood flow through the filter, and also on declining concentration of the endotoxin in blood and of the increasing saturation of the membrane. So these are the basic players of the adsorption process. Let's go over to COVID. What kind of disease is COVID from a very practical point of view? We had an advanced COVID unit in Lund. It is closed at the moment. We had at the most 17 patients inside this unit when we peaked. We are also an ECMO center, so we had actually the most critically ill COVID patients in southern Sweden at our hospital. In my opinion, COVID is a pneumonia. It is a hypercoagulable state. It is actually a cytokine release disease, and it is a multi-organ failure. These 4 points describe the disease quite well. There are several mechanisms in COVID leading to AKI. We have direct viral effects. They could be described best by a collapsing glomerulopathy, in my view. And then we have indirect effects coming from the critical care itself and coming from the multi-organ failure situation. Cardiovascular, cardiorenal, direct viremia, all kind of damage processes within the kidney, a hampered immune response, macrophages that are activated, and hypercoagulability. All these sum up with mechanisms that lead and result in an AKI situation. At our unit, we had an individual approach when to start CRRT on these patients, and basically we followed the KDIGO guidelines. So our approach did not differ from normal patients because COVID is a hypercoagulable state. The circuits are prone to clot. Many patients were, or actually all of them were already on low molecular heparin dosing, but citrate was the preferred anticoagulation method for us. On some patients, we lowered the post-filter ionized calcium target. At our unit, 105 COVID patients inside the critical care needed CRRT. And maybe we could see a trend towards increased fraction of patients in need of CRRT. Maybe this is because of more aggressive mutation. I don't know this. Our standard filter for the COVID patient was the Oxiris filter because it could deliver a standard treatment without any problem. It removed and blunted the cytokine pulse. There are good cytokines and there are bad cytokines. But for the COVID patients, we thought that it is good to blunt the cytokine pulse. Also, COVID patients were in shock state, they were hypoxic, and they had multi-organ failure, including an ischemic gut. And this caused, in our view, translocation processes from the gut, which could result in endotoxin levels in blood without a bacterial sepsis. All these arguments speak for using Oxiris filter as the standard filter in the unit. In my opinion, regarding cytokines, actually, we could divide the patients in patients who had something that could be defined as cytokine release syndrome, with elevated cytokines, but not a storm. And then a few patients had really huge amount of cytokines in blood. And for these patients, of course, it was beneficial to wash the cytokines out and to blunt the cytokine outflow. For these patients, we use an interleukin-6 inhibitor also, and for a very few fraction of patients, we could also connect a sorbent technique in series to the CRRT device. So I go back to endotoxin and cytokines. Endotoxin removal, many techniques have been tried. The Oxiris filter is an endotoxin adsorbing membrane technique. The filter has a PEA layer which can adsorb negatively charged molecules like heparin. It is pre-grafted with heparin from the factory, but also endotoxins. Cytokines attach to the AN69 bulk of the membrane. Here we see a schematic picture of the membrane. We have the PEA layer, which is itself positively charged, and it can then attach negatively charged molecules to it. And then we have the bulk consisting of AN69, which can incorporate cytokines. An expert group gathered in Frankfurt some years ago, experienced clinicians for discussions on when to use this filter with the aim to remove endotoxins from blood. And the main indication was agreed that it is a septic shock with adjacent AKI. Main criteria for starting was hemodynamic deprivation and dependence on a vasoconstrictor. And main criteria both for success and for terminating the treatment was a significant reduction of the vasoconstrictor need. We carried out at our region an own study where we tried to go into depth regarding the endotoxin balances in blood. The study setup was that we did a crossover regime. First, a patient got treatment with Oxiris filter for 24-hour or a traditional ST filter for 24-hour, and then the filters were switched so that we continued with the opposite filter for another 24 hours. This was a crossover technique. In this way, the patients could actually be their own controls. That was our idea. The inclusion was a septic shock, clinical septic shock, plus a positive pretoxin test with a level of above 0.03 units endotoxin per milliliter. The study was prospective and double-blind, and we gathered endotoxin and cytokine samples during the study periods. and of course also a large set of clinical parameters. So here we see the consort diagram of the study setup. Actually, we screened 57 patients. All of them were in critical septic shock. And for 20 patients, we found an elevated endotoxin level in blood. For the rest, I believe personally that they also had endotoxemia, but we couldn't catch the endotoxin pulse. It maybe was cleaned away before we managed to take the sample, or it was so that it came afterwards. The endotoxin balance is varying over time, and it is very complicated and dependent on many factors. So our endotoxin test is based on the LAL method. We have developed it and streamlined it into our laboratory. It requires skillful hands, and it takes at the moment about 90 minutes to carry out. So it is basically not possible to do it in the clinical production at the moment. We have gone a little bit further with our endotoxin test in order to try to simplify it. And at the moment, we have an endpoint of the test that either ends with a clot or with a liquid. And the clot is endotoxin present in blood, and the liquid is that there is no endotoxin in the blood. So to develop the test in this way could maybe in the future end with a test that could be carried out fast and simply bedside, but we are not there yet. So if we look at the period 1, the first 24 hours of our study, we could see that the baselines of the patients that got treatment with Oxiris differed significantly from the baseline of the patients that got treatment with the ST filter. So we were a little bit unlucky with our randomization here, but we can see, if we calculate the balance, that there was a significant endotoxin removal from the blood compartment with the Oxiris filter and not with the traditional filter. If we look at the norepinephrine dependence in the group, this is the first period, the first 24 hours in the crossover regime, and the group that got the treatment with Oxiris, we can see the gray columns that they had a higher norepinephrine dependence because they had a higher endotoxin level in blood. And from our number 4, the norepinephrine dependence was significantly lower compared to the baseline, whereas in the control group with the patients who got treatment with the ST filter, there was actually throughout the first 24 hours no change in the norepinephrine dependence. The period 2, the following 24 hours, was actually non-conclusive. The dependence of norepinephrine at this time was low in both groups. So how about the cytokines? Same thing. The group that got Oxiris first had higher levels of cytokines. All cytokines came actually nicely down, significantly down. What can be seen here that for certain cytokines like TNF-alpha and interferon gamma, they came not down to 0, and we can say that the cytokine pulse was blunted. It was not completely removed over 24 hours. If we look at the endotoxin concentration profiles and cytokine concentration profiles at period 2, the following 24 hours, they were non-conclusive, no significant change in either group anymore. So I go forward to another study from Italy, the OXIRIS-NET study, that included 37 patients, COVID patients in need of critical care. They were all treated with the OXIRIS filter. The main endpoints in this study was the interleukin-6 level and the SOFA score, describing the multi-organ function and mortality. The expected mortality rate based on calculation by using the APACHE-4 algorithm was 64.7, while the observed ICU mortality was 8.3% lower. So there was a slight better mortality, actual mortality compared to the expected mortality in the cohort. The interleukin-6 levels came nicely down during the treatment with the OXIRIS filter, and they correlated the concentrations of the interleukin-6 correlated with the SOFA scores. Also, the patients who got CRRT early, which was defined as less than 14 days from the start of the disease, they had an observed mortality of 47.4 against an expected of way higher, while in the delayed group, the patients who got their CRRT treatment later than 2 weeks from the disease start, they didn't differ in the observed mortality from the calculated mortality. So we don't know the final truth about the endotoxin removal story. We think that because we clearly can see that the endotoxins are there in real patients, and that we know that the molecule is detrimental, it should not be there. It is a motor for a negative and dangerous cascade in the patients. It should be removed. All patients in critical care have narrow margins. Of course, we must be very realistic. We must follow evidence-based clinical practice at all times, but we must also stretch borders with our patients and be in the front at all times, of course. With this, I thank you for my share in this symposium.
Kai, please, can you unmute? We cannot hear you. Thank you.
Sorry. Marcus, thank you very much for this very nice presentation. I would like to apologize. We had some technical issues in the previous presentation, so we were not able to see your questions. Please submit again. I only want to encourage you to please again submit your questions. This really was the only reason why we were not able to share them. Marcus, you mentioned the role of endotoxins and also that for COVID patients, because of, let's say, inflammation or hypoperfusion or whatever in the intestine, there might be a release of endotoxin. Do we know how high the levels are and how frequent that is? I mean, or what are your thoughts on this? how relevant is endotoxins? Probably I should ask.
We don't know actually nothing of this. There is no data available. But my personal view is that it might be more common than we think, actually. And therefore, this was one reason why we argued that for all our COVID patients that are in need of CRRT, we will choose the Oxiris filter as the first filter.
Okay, but as you mentioned, there's no you're not aware of any publication that has systematically assessed levels in these kind of in COVID patients.
No, and in a clinical scenario, to measure endotoxin is really difficult because the analysis is both expensive and cumbersome to carry out, and only very few laboratories can do it. This is for sure one reason.
And in a COVID patient, would you initiate Oxiris therapy other than in any other septic patient? You mentioned that in Lund you were basically also initiating CRT at the same time as in other patients, or would this be the same hold true for Oxiris as well, or not?
In our COVID unit, we used Oxiris filter as the first, let's say, 1 to 3 filters for all COVID patients. And the reason for this was that we argued that there might be endotoxin present in blood and that we want to blunt the cytokine pulse that we believe that the patients had. I also want to stress that actually for us, we never had any supply problem. So we could, we had filters available. And we had also possibility to choose what to use and to plan the treatments accordingly. It might be different if you have shortage of filters. You cannot change the filter after 24 hours. You need to run all filters 72 hours and so on. But we actually never ended up in such a situation at our hospital.
Okay. Thank you very much, Markus, for this very nice presentation. And we move on to the second video of today. This one is from Professor Akmalov from the University in St. Petersburg in Russia. And it will tell us about the Russian experience with blood purification in COVID patients. Please.
Hello, everyone. My name is Regina Akmalova. I'm a doctor of ICU from St. Petersburg State Medical University, named after Pavlov in Russia. I would like to share with you our experience of high adsorption membrane hemofiltration use in COVID-19 positive patients to reduce the severity of cytokine storm. Here in Russia, we're treating patients according to temporary guidelines of the Russian Ministry of Health, which recommend us to use such extracorporeal methods as immunomodulating technologies and plasma-modifying technologies. But actually, there is no specific algorithm for its use. So we performed a study with the purpose of creating the optimal way of application these methods in a clinical practice. In our study, we retrospectively analyzed the data on interleukin-6 and interleukin-18 levels in response to prolonged hemofiltration in a group of 69 patients with a different degree of lung damage. The indications that we used for CRRT were clinical signs of rapid progression of the disease, lung damage more than 25%, level of C-reactive protein is higher than 100 milligram per liter, level of ferritin is higher than 100 microgram per liter, and also progressive lymphopenia. The extent of lung damage was different. 4 patients had CT2, 44 patients had CT3, and 21 patients had CT4. So, according to severity of the lung damage, we use different duration of the procedure. For patients who had CT2 or CT3, it lasted for 24 hours. For patients who had CT4, it lasted for 48 hours. We used Oxiris filter on Prismaflex with citrate anticoagulation in vena-venous hemofiltration mode. The effluent dose was 30 milliliters per kilogram per hour. So the data that we received, the levels of interleukin-6 and interleukin-18 were tested before and after the treatment. And also the difference between their concentration was calculated. The potential association between the received data, degree of lung damage, and outcomes was analyzed. And as we can see, there was a significant difference in the levels of interleukin-6 and interleukin-18 before and after sorption. It was detected that the more lungs were damaged, the lower levels of interleukin-6 and interleukin-18 were, and vice versa. And this correlation was not associated with the use of tocilizumab admission because almost all of these patients had received it. The maximum decrease in cytokines levels was observed in a group of patients who had CT2. There was a significant association between the delta of interleukin-6, which reflects a decrease in its concentration, and outcomes. Only 18 patients are not survived. There were 11 patients that had CT4 in a survival group. So I would like to summarize our experience. As the inflammatory process progresses in the lungs, the levels of interleukin-6 and interleukin-18 decrease, which may be a manifestation of the depletion of cytokine storm. According to this data, perhaps it's better to initiate hemofiltration and cytokine sorption earlier. The use of prolonged hemofiltration and cytokine sorption reduces the level of interleukin-6 and interleukin-18. It should be kept in the mind that the more the lungs are affected, the lower the value by which cytokines decrease. Probably we should perform this procedure more than 48 hours for patients that had CT4. The delta value, which reflects a decrease in interleukin-6 concentration, significantly correlates with the outcome, which makes it possible to recommend the use of hemofiltration with sorption not in discrete but in continuous mode. Thank you for your attention.
Interesting. Yeah. Again, this was pre-recorded, and therefore there is not a possibility to ask any questions to the presenter. But I found it interesting to see a different approach from Russia with very specific definitions of treatment initiation, and yeah. We will move to now our next topic, or next final, last but not least, presentation from Professor Javier Neira. Professor Neira is a nephrologist at the University of Kentucky in the US, and he will share with us his experience in extracorporeal blood purification in COVID-19 patients, the US experience. Please, Professor Neira.
Thank you very much for the invitation to this symposium. Very happy to be here and happy to share a little bit of our experience with blood purification during this pandemic. I'm gonna start sharing my slides. Are you able to see the slides? I'm not sure if I'm doing it correctly. Let's see.
Javier, you did have it on screen there. You just need to please go into full screen mode on your PowerPoint presentation.
Okay, so first go to first screen. Okay. So
Thank you.
So share screen and go here. Perfect. Okay, so the topic today is going to be extracorporeal blood purification in COVID-19. I'm going to focus a lot on what we did at the University of Kentucky. These are my disclosures. And the outline first, we're going to discuss a little bit about blood purification. I know there have been very interesting, informative talks before during this symposium, COVID-19 pathobiology, and some comments on blood purification in this context. So importantly, we need to recognize that acute kidney injury, it's very frequent in the ICU, occurs in about 50% of the patients that are critically ill. Now, severely ill patients with acute kidney injury have also high mortality rates, up to 50%. So this interplay between AKI and critical illness generates this relationship constantly between intensivists and nephrologists, particularly for extracorporeal organ support, CRRT, and now blood purification. 5 to 10% of hospitalized patients with AKI require RRT, and severe AKI in the ICU occurs mostly in the context of multi-organ failure, which requires a more comprehensive, holistic approach. And in this context, extracorporeal organ support has gained interest in the management of critically ill patients with acute kidney injury and multi-organ failure, particularly during the COVID-19 pandemic. Now, when we talk about extracorporeal organ support, we need to identify that there are many devices can support different organs. RRT, the most common one, supporting the kidneys, homeostasis, fluid management, extracorporeal CO2 removal. We have our ECMO devices we use all the time, ventricular-assisted devices to support the heart, liver support systems, and importantly, hemoperfusion for blood purification, and other blood purification devices as well, where we have, for example, selective cytopheresis and other techniques. This is just a diagram to represent that now in critical ill patients, we can have multiple organ support devices that can really support the patient comprehensively. And it's create a lot of excitement in the field. And of course, a lot of challenge as well, how to integrate all these therapies and how to develop the best practice based on evidence. Now, to talk about blood purification, we need to review a few concepts of COVID-19 pathobiology. Of course, we recognize the time course of COVID-19, the early course of viral response phase, where some of the patients reach the hospital, but not all of them will develop severe disease. The ones that develop severe disease typically will develop this stage 2 of pulmonary phase, most of the time pneumonia, hypoxia, abnormal chest imaging, and infiltrates in the lungs. And then they will progress to this hyperinflammatory phase in which these patients develop multi-organ failure, ARDS, they sometimes develop shock, cardiac failure, AKI, and importantly, when we measure certain markers of inflammation, we have elevation in CRP, LDH, IL-6, D-dimer, and others. And of course, at this stage is where, in addition to steroids and some medications that help with immunomodulation, is there a role for extracorporeal blood purification to mitigate this inflammation, right? That's the key question. Importantly as well, that this hyperinflammation can also affect many organs, and the kidneys is one of them. And a lot of the times, among the causes of the AKI, the most clearly recognized pattern is acute tubular injury, ATN, which could be in part related to this hyperinflammatory state, among other causes, right? Like rhabdo, the interplay and the crosstalk between the lungs and the kidneys, and also all these molecules that are circulating like DAMs or PAMs from lung injury that can affect the kidneys. Of course, this is not the only cause of AKI. AKI can occur in this context of COVID-19 due to other causes like hypovolemia, particularly in the viral phase early on, the hypercoagulation. There are cases of TMA and also some glomerular vascular involvement. Of course, the hemodynamic compromise of some of the patients, and this also observation of direct invasion of the virus that has been consistently demonstrated in some studies, but not in all. So it still is an area of investigation, but it has to do with these ACE2 receptors and this ability of the virus to invade some proximal tubular cells. This is a diagram you have seen many times, a very nice diagram from Professor Ronco. That highlights this interplay between multiple organs during acute illness in COVID-19. Particularly, one of the centerpiece of this multi-organ dysfunction is the hyperinflammation and the hypercoagulation. The kidneys are involved as well as the heart, and how we can provide best therapies to support these organs in a timely manner and in an effective manner as well. That's the challenge. Now, when we recognize which patients develop these complications, organ failure, including AKI, in this nice study from New York, one of the earlier studies, close to 2,000 patients, risk factors that were recognized for these patients were older age, Black race, hypertension, diabetes, cardiovascular disease, vasopressor use, and need for mechanical ventilation. So very similar risk profile to patients without COVID-19 that are in the ICU with AKI and other multi-organ failure. So that's not very different in COVID-19, although there may be some genetic predisposition in some patients, particularly that observation of Black race. This is another registry from the US, Stop COVID, was done in 65 US sites, more than 2,000 patients. Just to highlight that the incidence of AKI these are all patients in the ICU, 43%, and the mortality was 35% in these patients. And importantly, the need for acute renal replacement therapy was 20%. So certainly, these patients were requiring higher resource utilization. Mortality was 1/3, and the complications of organ failure were very frequent. This is just to emphasize that it's not all related. There may be some interplay between genetic predisposition and the viral infection. In this case, this is the APOL1 high-risk alleles. when they have identified in this particular study, this was one of the earlier ones, 6 Black patients with COVID-19 that developed AKI and also proteinuria. In these patients, the biopsy results were consistent with collapsing glomerulonephropathy and severe AKI. Of course, all required dialysis. As you see in the slide, a couple of patients died, and 4 of the patients required dialysis, and only 1 recovered. So here, the important finding is that patients were identified to have at least 2 APOL1 risk alleles to have this phenotype of collapsing glomerulonephropathy and very severe adverse events. So that's also something to keep in mind when we talk about COVID-19. So to summarize, COVID-19 epidemiology, AKI is very common in patients hospitalized with COVID-19. Incidence of AKI is estimated about 15 to 25% and up to 40 to 60% in the ICU. 20 to 30% of ICU COVID-19 cases require renal replacement therapy, and the most common indication for renal replacement therapy was fluid management in these patients, and also oliguria. So, of course, we are all interested in blood purification. So just to sum, what is blood purification? What's the goal? It's this concept of immune homeostasis, right? So it's basically the role of restoring a balanced immune response by eliminating or deactivating inflammatory mediators, right? Not every mediator is pro-inflammatory. There are mediators that are anti-inflammatory. So how to keep that immune homeostasis, especially when we apply therapies like blood purification that are non-selective, right? As it is CRRT, right? In CRRT, we cannot be selective on solute removal. The machine is not as smart as the kidneys to determine this is good, we're going to keep, or this is bad, we're going to remove. So that's the challenge, right? So that's why there are questions: how to do it, when to start, when to stop, and how to monitor it. So it's not a simple task, right? As we know for CRRT, and there have been many studies of clinical trials of the timing, for example, of initiation of renal replacement therapy in critically ill patients. We know that one size does not fit all. So that's important to recognize. That apply also for blood purification. So perhaps there are some patients can benefit from it early on, others may not benefit, and we need to wait. That's the challenge, how developing this evidence and how to standardize a little bit our practice, right? So, but it's exciting because we all agree, or most of us agree, that these therapies could be beneficial to certain patients. It's just we need to identify who are these patients and how to standardize our treatment. Now, of course, if we talk about extracorporeal organ support in COVID-19 patients, we talk about there are many devices, right? Starting with our mechanical ventilation, the most common one, our ECMO support for supporting those lungs that are injured. But certainly, blood purification can also have a role here, and particularly in patients that have this hyperinflammatory state. Now, how we do it? There are many ways to do it. Cytokine removal or endotoxin removal, as it was discussed, can be targeted with hemoabsorption, use of biocompatible sorbent cartridge, hemofiltration. Don't forget that hemofiltration can also remove middle-sized molecules, particularly if you prescribe it in a high dose, and if you use filters that can have middle-sized molecule cutoffs, right? So you can also have this high intensity or high dose CBBH or hemofiltration, and the use of medium or high cutoff membranes. And of course, don't forget plasma exchange can also remove large molecules, middle-sized molecules, including inflammatory mediators. The problem is that it's non-selective, right? So not everything we remove, it's beneficial for the patient. So at the same time, there are other ways like immunomodulation with selective cytopheretic devices and devices that can remove pathogens that doesn't directly necessarily affect the inflammation, but also can impact the course of the infection. This is just to refresh our mind that still when we do hemofiltration, we can remove middle-sized molecules. If you see in the x-axis, the molecular weight of 10,000 Daltons, where with hemofiltration, we can remove some middle-sized molecules. And of course, if we use high cutoff or middle cutoff membranes, we will be able to remove consistently these middle-sized molecules and affect these inflammatory mediators. Now, this is a summary of studies that have used this concept of high volume hemofiltration. So if we agree that with convective clearance we can remove middle-sized molecules, how about if we apply high intensity convection in specific scenarios, like you can see there in the column of participants, patients with sepsis, most of them with sepsis, or post-cardiac surgery, patients that develop severe shock. So patients really in hypercatabolic states, in hyperinflammatory states. So is there a benefit if we can use high intensity hemofiltration? And as you can see, the doses were 50 versus 85, 35 versus 70, or 80 mLs kg hour. So these are very high doses, right? Typically, we don't prescribe these doses currently in the ICU settings. And there were no difference in outcomes in terms of mortality at 28 days or 30 days, and in AKI recovery in these patients. These were all randomized clinical trials, but as you can see, small size studies. These are difficult studies to execute, but there is no really signal necessarily of improvement in clinical outcomes, though when, especially in the study of PARC on the bottom, when they measure inflammatory mediators, cytokines, yes, it's clear that with higher intensity hemofiltration, you can remove more inflammatory mediators, but unfortunately, the studies did not show an improvement in mortality. Now, if we go to hemabsorption with the biocompatible sorbent cartridge, so you can see here, this is one of the filters have been used for many years, Cytosorb, that has this polymer technology of bead, these beads that can enhance absorption and can be used in different settings. You can use this filter as hemoperfusion per se, as you can see in the top left of the slide, or you can use it in tandem with CRRT, either before the CRRT filter or after the CRRT filter. You can use it in connection with the ECMO circuit, or you can also use it with the cardiopulmonary bypass system. So in COVID-19, there was this study published a few months ago that we need to take with a salt of caution because it's a small study, it's a randomized clinical trial that included 34 patients that had severe COVID-19 pneumonia and require ECMO. So in these patients, they randomized to receive the ECMO with the Cytosorb enhancement for hemoabsorption versus the ECMO under standard conditions. And the study was powered for the primary outcome of reduction, a significant reduction in interleukin-6 after 72 hours of initiation of the ECMO circuit. So the study randomized 34 patients, one-on-one, and did not show any difference in significant reduction in IL-6 in patients that received the ECMO plus the Cytosorb. That it's okay, but the critical part of the study, despite this was a secondary outcome, 30-day mortality, and you can see the Kaplan-Meier there on the right side of the slide, show that patients that received the ECMO with the enhancement of hemoabsorption had decreased survival, as you can see there with the Kaplan-Meier. So something to keep in mind. As I said, this study is a small study, and these are only patients that were exposed to hemoabsorption early in the course of ECMO, and patients already had severe disease that qualify for ECMO support. So we need to keep this in consideration. Now, the other filter that we have some experience with, and we have used it at the University of Kentucky, is Oxiris. I think there was a very nice presentation about talking about Oxiris and the removal of cytokines and endotoxins. But just to summarize briefly, this Oxiris filter has 3 layers. The first layer has the AN69 copolymer structure that it's negatively charged and will absorb cytokines, right? And typically the cutoff for absorption here will be 40 kilodaltons, right? So middle-sized molecules, so we will be able to absorb these cytokines and remove some cytokines here. The second layer has this PEA component that will improve the biocompatibility of the filter, but also will help with absorption of endotoxins. And as you can see in the diagram there. And the third layer that has this heparin grafting that will reduce the thrombogenicity and will help maintain this filter viable and functional the longer as long as possible. So this Oxiris filter also was approved for COVID-19 under emergency use authorization in the US. And for that reason, we were able to use it at the University of Kentucky. In summary, it's a filter that can provide kidney support because you can still provide the similar convective or diffusion clearance that you want with CRRT. In addition, it has this enhancement of cytokine removal, endotoxin removal, and local anticoagulant treatment. Now, a very nice study from the Italian group, this is an observational study. They evaluated 37 patients with COVID-19. 70% of them had acute kidney injury. This was early in 2020. These patients received CBB-HDF, effluent dose standard around 30 mL per year per hour. And most of them also received the treatment with regional citrate anticoagulation. So what they found is that the mortality in these patients was 56.4%, and they compared this with a matched group according to Apache 4, similar type of patients, 64.7%. So maybe some signs of a decrease in mortality, but keep in mind this is a observational study. This is not a randomized clinical trial. This is just a reference in terms of mortality with matched patients. Importantly, they did not find significant events of infections or adverse events related to the circuit, and there was premature clotting in 18.9% of the treatments, defined as less than 24 hours of clotting after initiation. Importantly, they did show that there was a significant decrease in IL-6 levels in the first 24 hours, 48 hours, and 72 hours was sustained with the use of Oxiris. And most importantly, the SOFA scores improved as well concomitantly with the reduction in the cytokines, in this case, IL-6. So as you can see in the right side of the diagram, the SOFA scores were down. Very important parameter, right? Now, of course, you just need to be careful. This is observational data, but suggesting that Oxiris was safe to use and was able to reduce IL-6, improve SOFA scores, and perhaps can have some impact on outcomes such as mortality, although a clinical trial needs to be done to confirm this. Now, our experience, we have this cohort of patients from March 2020 to April 2021. As you can see, a fraction of these patients, 114, had COVID-19, and the others, the 448, did not. So just to have an idea of the patients with COVID-19 tend to be a little bit older. Then the race was a little bit more heterogeneous than the typical CRRT population we see at the University of Kentucky, and the Charleston scores were a little bit lower. And of course, as you can see, these patients require more ECMO support for respiratory failure comparing to the standard CRRT critical ill population without COVID-19 at our institution. So we created, under the emergency use authorization, this protocol in which we use Oxiris for every patient that requires CRRT for COVID-19 support in the first 48 to 72 hours of treatment. So every time we start a treatment for the first 72 hours, we will use Oxiris, our default filter. And the difference here is that the priming of the filter will be used with 2 liters of saline with heparin. So you need to use 5,000 units per liter of priming solution. That's the only thing that is different comparing to using another standard filter. In the past, we were using HF 1400 for these patients. So if a filter change is required within the first 24 hours, we allow another Oxiris filter to be changed. But of course, we limit the use of Oxiris to the first 72 hours. This is not evidence-based. This was done to maximize the utilization and to be able to have enough supply to at least provide 72 hours of this treatment to all patients that we feel can benefit from it. So this is one of the questions that needs to be done, right? When to start, and also for how long, right? When to stop. So those are the things. What are those parameters can help us guide our treatment, right? But we needed to create a protocol to execute and to provide the best treatment with the evidence we have on hand. Contraindications, allergy to heparin, and patients that have HIT positive, and of course, concomitant use of ACE inhibitors because of the AN69 component of the filter. very unlikely to find in the ICU patients that are receiving ACE inhibitor actively. So the first question I wanted to answer was, is this filter that has this enhanced hemoabsorption property, is it going to clot more frequently? And are we going to have a lower life of the filter comparing to the HF 1400 we used in the past? And we, as you can see there in the table, we use a lot of Oxiris filters from April 2020 to April 2021. And when we compare the average filter life of Oxiris versus HF 1400 was very comparable, 38 hours versus 37 hours. So there was no difference. So this enhanced hemoabsorption was not creating this filter to fail more frequently, to clot more frequently, what was something we wanted to be sure is not happening. So the other thing that we start to see is all patients, these are just to have an idea of patients on CRRT during this period of time, the mortality in our institution is 64.6%. Patients with COVID-19 tend to have a little bit higher mortality, 75.2% comparing to the non-COVID AKI patients that require CRRT. So yes, we knew these patients were a little bit sicker and perhaps need to have more intense treatments. And that's why we supported our decision to keep using these enhanced hemoabsorption techniques. Now, the other question I wanted, of course, to determine is, there is a sign that the patients that are receiving Oxiris versus not. Now, I did not mandate the protocol because, as you know, this is under emergency use authorization. I said I created the protocol to be able to be used, but of course, I have colleagues at my institution that may not be comfortable with using Oxiris as others. So for that reason, we still have some patients that during this period of time did not use Oxiris as we wanted on the protocol and use the default filter HF 1400. And so in this differentiation in this table, we classify Oxiris exposure as at least a patient that received 12 hours of this enhanced hemoabsorption with Oxiris for the first 72 hours of CRRT. So in this initial excursion, we identified 21 patients that meet this criteria versus 75 patients that did not. And when we compare the characteristics, particularly in terms of mortality, there was not really a signal of a difference in mortality, but the numbers are small, only 21 patients that meet the criteria of exposure to Oxiris. Mortality was 71% versus 68% with the HF 1400. And importantly, and that's something we wanted to answer, is that there were no adverse events related to the use of Oxiris filter in our institution. Now, the other thing, now we went not necessarily into documenting the average filter life, but going into the data card of the machine. So this is all the big data from the device, right? So as you can see, the average filter life of Oxiris was actually very good. So the filters were lasting close to 70 hours, the HF 1400 around 45 hours, as we typically have been tracking for the last several years. But the Oxiris was lasting probably because the nurses were paying more attention to these patients, and we were trying to do our best not to minimize trips into the room to change filters, right? So I think that's a pretty good signal there. And then when we compare, for example, access return alarms were very comparable between Oxiris and HF 1400, perhaps a little bit more in HF 1400 in the first 30 hours, and maybe a little bit more sustained, although very gentle, in Oxiris throughout the second 40 hours after initiation of the treatment. And then these are the pressures in terms of the pressure drop and the TMP. So I'd like to see if this filter clotting more. As I show you already, the average filter life, you would say, I don't expect these filters to be clotting more because the average filter life was pretty good. And as you can see here, very comparable pressure drop trajectories and TMP trajectories between the Oxiris filter and the HF 1400. Similar for the trends of the access return pressures. So to finalize, I just want to say that during the COVID-19, there have been many challenges. Supply chain has been a problem, and that has affected, of course, the provision of CRRT and hemoperfusion, the shortage of staffing, the training of ICU nurses, the complex schedule rotation for the provision of these treatments, and the availability of some devices, including portable reverse osmosis when we provide HD in the ICU, local expertise as well to provide PD and insert peritoneal dialysis patients during ICU stay for patients that are critically ill. To finalize, this is a very nice editorial from my colleagues in Canada and around the world. And it's to balance that hemoperfusion, yes, we can remove cytokines, but not every cytokine is bad. There are cytokines that are pro-inflammatory and cytokines that are anti-inflammatory. If we remove cytokines that are pro-inflammatory, we may improve some outcomes, organ function, survival on the patients, but also we can create immunosuppression, right? Increase, and this can enhance viral damage or maybe secondary infections. Not atypical secondary infections with the Delta variants of COVID, right? You have seen this a lot. If we decrease anti-inflammatory cytokines, we can enhance inflammation, and we can also have the opposite effect on these outcomes. So that's why we need to balance. And to balance, I think we need to answer some questions of which are the patients can benefit the most, and what is that timing of provision of this hemoperfusion that can impact their outcomes. This is the key to answer. And of course, as Dr. Mehta said it, the collective collaboration and the ability to exchange our experiences and develop high quality studies together that we can execute hopefully can give us some answers in the near future that we can apply not only for COVID-19, but for other septic shock environments that we face commonly. So to finalize, mechanisms of potential benefit are poorly understood still in blood purification techniques. There is non-selective removal of inflammatory mediators, DAMs, PAMs. The timing of application is sensitive, preferable in the first 48, 72 hours of severe COVID-19 multi-organ failure, although this needs to be supported with more compelling evidence. It is unclear its role in secondary infections, and randomized clinical trials are needed. I know there are some plans, some ongoing, so the future is very exciting, and I thank you very much for your attention.
Thank you very much, Javier. Very interesting talk and very nice presentation. First of all, maybe if you allow, I would like to make a comment because you were comparing the Osiris filter to the HF 1400 filter, which is a polysulfone filter. And this is just for the colleagues outside the US, so to speak. In the US, the standard filter is a polysulfone filter, which is not AN69 based membrane and has no absorptive capacities whatsoever for cytokines. The ST filter that is more commonly used outside the US as a standard filter is an AN69 membrane and has some absorptive capacities for cytokines. It is now under an EUA in the US as well. EUA means emergency use approval. So just for the as a comment to this, Javier, you were mentioning there's this old discussion about good and bad cytokines, and there are some people that you mentioned also that have developed some theories about it. So for example, I heard Claudio Ronco speak about the peaks that you need to be removed. John Callum has also talked about, that the origin of an infection can be masked by the both pro and anti-inflammatory mediators, and that needs to be removed until the immune system can really attack the origin of the infection. Do you have any comment on those theories, I would say?
Yeah. I mean, of course, there are many ideas how to best apply these therapies. I think there is certainly an observation based on the clinical data. And again, these are all observational data, that the earlier you apply the treatment at the time of you can have these peak parameters of hyperinflammation, the higher the chances of success. For that reason, when we said if there is a chance to help these patients with Osiris and we want to give the maximum benefit possible, We just need to use it as soon as we start CRRT, independently of having some results of IL-6 or CRP or any specific cytokine. We were trained in some cytokines, but sometimes if that happens, because we wanted to minimize the nurses to really be changing filters. So if you have a patient you need to start emergently, and then you're sending all this battery of cytokines, and then you just put the standard filter, as you described it very nicely. We use the HF 1400 here. And then several hours later, you have the battery of cytokines, and they need to go back and change the filter. It's not going to be very practical. So we said, we are going to assume that a patient that reached this state of needing CRRT for other reasons, have multi-organ failure, already has some signs of inflammation. We are going to use the Oxiris as default, and we're going to track the data from there. So this is just an approach we took that we thought is going to be easier to implement. But that being said, I think with that strategy, we are capturing some patients that can benefit the most, but certainly not every patient is benefiting from it. So, and that's the challenge. So having quick ways to risk stratify patients that the hyperinflammation is not only present, but it's at a point that affecting it can impact patient outcomes. So I think that is, and there is, the answer could be a panel of certain inflammatory mediators that we can check, and that can be easier to apply, easier to be available at different institutions in different parts of the world, that we can standardize a little bit the treatment. But certainly, if there is a chance on this treatment, will be early on in the course of the disease.
Yeah, I thank you very much. Again, timing seems to be crucial here, and that is not really solved at the moment. How to define this ideal timing? Maybe besides the parameters that you mentioned, there could also be clinical parameters that could play a role in the decision making. We have a couple of questions actually now. Thank you for that. One is, can the absorptive therapy be selective for bad cytokines and not good cytokines?
I will love that. That's exactly the ideal treatment, right? But as I said, like in CRRT, we have the same, right? So we remove solutes that we want to remove. Let's say the hyperkalemia, we're removing the potassium, but at the same time, we can remove nutrients. We can remove amino acids of the patient. We can remove antibiotics. So, and we have learned with years to use it to the best advantage of the patient. So I think the challenge in hemoperfusion, yes, can we advance the technology to be more selective? That's a very good point. And but at the same time, we can get smarter into patient selection, timing, and also monitoring of the treatment, right? Still, we struggle a lot when to stop CRRT. So in hemoperfusion, we haven't even figured it out the best patient selection indications yet. There is a lot to be done, but that provides a lot of excitement in the field and justify our presence here, right? So it's a lot of things to discover, but we have better tools now, as you mentioned it. We don't forget not only biomarkers, the clinical data may be very helpful, and now we have machine learning algorithms can help us to navigate the patient characteristics a little bit better. We have the data from the machines. I show you today how the machine can provide these trends of data that can help us to maybe identify some patients that even we can track the hemoabsorption capacity of the filters, and then say these filters are really constantly being saturated, and perhaps then are doing their job or not. So I have a lot of ideas, and but I think as of now, unless there is something I don't know that is being developed, we cannot be selective on what we remove in terms of good and bad. And also the question becomes more philosophical, right? Do we know what's good and bad?
That's a very nice answer. Next question, is there any anaphylactic reaction with the AN69 membrane? I don't know, are you, I mean, again, this membrane is not the standard membrane in the US and it doesn't exist. Are you able to answer the question, Javier?
Yeah, we use it. We use it in the past. I remember many years ago, we used to use the AN69 base membranes, and I have only encountered, at least myself, the one type B reaction with this filter. Of course, this is bradykinin release related, and most of the time patients have some predisposition. The most common one is this ongoing concomitant use of ACE inhibitors. And for that reason, in our protocol, we just put that cautionary note, which is very unlikely to occur in ICU patients, because ICU patients that are in the evaluation for CRRT are typically not receiving antihypertensive and certainly not ACE inhibitors. So that's not very common apply exclusion criteria, but it's very unlikely to occur. And I think also these AN69 technologies have evolved to the point that are less now prone to this type of either type A or type B filter reactions anymore, right? So
this is the reason why the ST membrane has been developed and is now used. So this is not the former AN69 membrane where these reactions potentially have been described. Maybe as a last question, because we're getting at is there something like an adsorptive dose similar to dialysis dose?
Yeah, that's a very good question. I don't think like we know exactly what's the best absorptive dose, but technically when you apply, for example, Osiris, your absorptive dose will be mandated by still your total effluent dose. So there is no any indication that you should prescribe higher dose in total effluent. What is your 25 to 30 mLs kg hour, right? As you saw that study from Claudio Ronco, they prescribe on average 30 mLs kg hour, and they show very nice reduction in interleukin-6 and improvement in SOFA scores. In our protocol, we prescribe the same standard dose of 30 mLs kg hour. So you cannot control specifically the absorptive dose, but you should still be able to control your total effluent dose.
And maybe to add to this, if you may, I believe there's also a huge heterogeneity in the expression of, let's say, IL-6. And so to determine how much needs to be removed and when, at what level this becomes clinically relevant, I think is very difficult, at least at the moment.
Absolutely. Yeah.
So again, Professor Neira, thank you very much for your time and your very nice presentation. Before I hand it over to my colleague, Dr. Kamal El-Attar, I would also like to thank everybody for their participation. To me, I hope this has been as interesting for everybody as it was for me. And with that, I'll hand it over to my colleague, Dr. Kamal El-Attar, who is the medical director for the Middle East and Africa region in Baxter.
Thank you, Kai, for the kind introduction, and Professor Neira for a great presentation. And definitely, we've seen experiences today from. We started from the experiences from Sweden, followed by experiences from ICUs in Romania. We saw the Austrian experience presented by Professor Ioannidis. We went to see the experiences from the US from Professor Mehta from the West Coast. And then eventually we got more experiences from Russia, where they are doing specifically extracorporeal blood purification from St. Petersburg. We also saw experiences from the East Coast, maybe from Kentucky, from Professor Neira, all of them sharing lessons from what was an unprecedented pandemic in these areas. Vaccination rates are very different in our region as ICEMEA. We have countries at levels of vaccination above the US, with above 67% vaccinations in the region. We have also countries with very low vaccination levels. So we are actually learning from these experiences from the countries who have already recovered from the peak, but also moving forward, we would like to share what happened as the post-COVID stage, or what happens after the tsunami is over, as it was expressed today. For those of you who did not attend from the beginning, we have the link that you can view all the presentations. You can review them again for up to 30 days. That will be sent to you. So feel free to if you joined late, or if you want to visit one of the presentations, please access that link. We will have a survey afterwards. That survey also, we kindly request that you complete that survey, so we have to know in the future what can we do better in terms of webinars or in terms of hybrid events. Also, we have had today a phenomenal participation from the East Central Europe, Middle East, Africa region. We had over 500 doctors, nephrologists and intensivists coming from all different countries. Top countries are presented: Kuwait, Qatar, Saudi, Egypt, Italy. We had Iraq, Romania, parts of Poland from Europe, South Africa. We had maybe over 30 countries where people were participating today. This is by far our biggest audience for the Baxter Ace Symposium. We've always had it physical with maybe 100, 150 doctors, but to have it virtual, we were able to reach a bigger number of doctors. Unfortunately, it's not face-to-face, but we're very glad that we could personally, be in touch with that number of people this year. I've been to countries where vaccination rates are higher, and definitely things are much calmer now, and it's maybe time for us to reflect on the experience and even share it, or maybe that will be the title of our next meeting, hopefully next year, what we done after the pandemic has subsided. Thank you everyone again for your time. It's been a pleasure for us having you here today. We do appreciate it's dinner time for some of us. It's even past dinner time for some of the countries. Your time away from your family, your patience. We do appreciate that very much, and wish you all a great evening.